थैंक यू वैभव जी। अतिथि देवो भव। अतिथि उस ईश्वर के समान है, उस भगवान के समान है जिनकी हम पूजा की जाती है, या हम उनसे दुआ करते हैं, प्रार्थना करते हैं। आप सब अतिथियों का जहाँ पर इस विश्व हीमोफीलिया दिवस के उपलक्ष्य में 2 दिन के कार्यशाला में आपका स्वागत है। मैं पर्टिकुलरली आज के इस कार्य के अतिथि एस गोविंदराज जी हैं। जैसे कि हम जो भी प्रॉब्लम्स के साथ हम आगे बढ़ रहे हैं, जिन जिन दिक्कतों के साथ हम आगे बढ़ रहे हैं, डॉक्टर्स ही उसमें से हमें हमारे जीवन की नैया को पार लगा सकते हैं। मैं उन सभी डॉक्टर्स का भी इस उपलक्ष्य में आपका वेलकम करूंगा। और मैं उन सभी चैप्टर की पर्सन्स का, जितने भी चैप्टर की पर्सन्स हैं जो ग्राउंड लेवल पर हीमोफिलिक्स के लिए काम कर रहे हैं, मैं उनका भी इस प्रोग्राम के अंदर वेलकम करता हूं। मैं अपने प्रेसिडेंट एग्जीक्यूटिव कमेटी ऑफ द हीमोफिलिया फेडरेशन इंडिया, आवर सीईओ श्रीमती मिस सरंगा पवार, मैं उनका भी इस सभा में, इस कार्यक्रम में मैं उनका भी वेलकम करता हूं। और मैं ये आप सबसे ये आशा रखता हूँ कि आप सब लोग इस कार्यक्रम में अपना एंजॉय करेंगे और कार्यक्रम को पूरी तरीके से सुचारू रूप से आगे चलाने में अपना योगदान देंगे। धन्यवाद। थैंक यू। वैभव जी प्लीज।
कर्नल ज्योति कोटवाल, like uh,
awareness and education and getting up with every need is the need of the hour with early diagnosis. Coming back to what is a blueprint, what can give us this kind of a care? It is having in the state, in every state, having at least, we want every district, but at least 2, 3 no, diagnostic lab which can diagnose from hemophilia to any other rare bleeding disorders. Then moving on, we want all the districts to have some kind of a treatment. And at least have 1 to 3 comprehensive treatment centers in the state. When we are asking for factors, we want the whole gamut of medicines. It's just not factor 8. You should understand hemophilia is just not factor 8. There is factor 9, von Willebrand, and we need non-factor therapy also. Sometimes we buy medicines. The states buy a lot of medicines, and a very good system is in place. But maybe we should really re-look into the method of distribution and the percentage of medicines which we are buying, whether we are buying the right percentage of medicines in the budget we have. So that's something which the committee has to really look in, because suddenly what happens is factor 9 is out, okay, or inhibitor medication is out. It's important to buy medicines to ensure that there is treatment available 365 days. We are always there to educate and train medical focus. We have to work further on prevention. Disability certificate is something which is being granted, but processes should happen more smoothly across India. Some states are facing major challenges in this. We want to, the insurance coverage has been technically given, but in reality it's not there. So we have changed our vision to getting the insurance coverage to making it a reality. The request is little more emphasizing on surgical and critical care. Basic care, I think we have achieved a long way in providing basic care, but we have to look at more of critical care and also look at prevention systems. The reservation is something which we would like to give a big thanks to our NHM, okay, Government of India, for including hemophilia products in the essential drug list. Okay, and also one of the requests we were saying is data is very important for procurement and distribution. So the government has taken a step forward and put hemophilia in the sickle cell portal. We want to congratulate and thank them for doing that. But we would want them to re-look at products which they put into the essential drug list, that some of our products have been left out, like non-factor therapy mainly. We request them to do it, and we request all the states, okay, not to, I mean, this reference is there, but we can always, states have their own drug list. It will be great if we can bring in the gamut of von Willebrand and non-factor therapy, including inhibitor medication and factor 8 and factor 9. We want to make a committee to make the national treatment guidelines. Thank you so much. Thank you to the entire hemophilia community and everyone here. Thank you so much.
Thank you all. I will now like to request government the dais this our gathering.
All gathered here. It's a highly impressive that a significant day we gather here to discuss on an important issue. Or moreover, we can say we are here to sensitize the rest of our country through this significant day discussing on several other related matters, population, the poverty, and so many things. Talking about years together, decades together, but we are in a response. We have the responsibility of finding some solution to overcome all the shortage or shortfalls. So we are at that juncture now. We need to see how to resolve instead of discussing about the lacuna. And all the discussion should lead to one point, that is resolving through some positive steps. I think there is a formal and a well-structured system and the society. The structure is over there with the Hemophilia Federation of India and more than 100 societies across the country. That itself gives a good note, right, for the development, for a mutual and equal development, knowledge sharing, and adopting the expertise across the, even from across the world, can import and can impart. We need to regularize it. The government supplies essential medicines at free of cost in all the government hospitals and to the renowned NGOs also. We need to regularize, but what the information I get, the supply is insufficient. So we need to increase by quantity and identifying the qualitative medicines. Right. Of course, the highest demand or the request, we could say, we can put it in such a way that related to livelihood factor, that is job opportunity for blood disorder or affected people. Of course, RPD Act 2016 gives relief to all 21 types of disabilities. All it could this act is an all-round solution for everyone. But as you all express that blood disorder, not though it is included in the notified disability, it is not mentioned in the job reservations. Several cases are registered against this, but we consider such a discrimination cannot exist. But we say reservation, in the reservation column section 34, the word hemophilia, thalassemia, and sickle cell anemia, these words are not mentioned. That doesn't mean they are not for reservation. We need to do some deliberation over it. Yeah, we have recommended Department of Empowerment of Persons with a Disability is in the effort of considering of the inclusion, and soon we will get a positive result. And it is very evident. I was told that this act considers that these group are unfit for job. No, not like that. Because we have evidently, we are seeing several doctors affected by hemophilia, several professionals affected by thalassemia, right? Really, have plenty of examples. So nobody could say that are unfit or not suitable for jobs. We are also in the effort of collecting the data about the professionals who are on job or the society practicing independent professions. So to take it to the expert committee where they would describe or um, bring into the list as an identified positions for the persons with the disabilities. So you people can also uh, different fields so that we can, our rule, RPD rule says, if any one person of the affected that a PWD holds a position, that becomes a suitable. So that this effort of collecting the data would result in better way to reserve or to become an identified post for persons affected with blood disorders. Long to get a positive results over this problem. So apart from that, yeah, what the knowledge we have is proven to be very limited. We were thinking that only the male or sufferers and females or carriers. But recent development and the knowledge says even females are affected and becoming the sufferers. So that case, the awareness needs all the cause for the disability should be identified between 0 to 6 ages. Once it is identified, curability or is very high. Otherwise, the treatment, severe treatment could reduce the problem, not completely curable. So we keep talking about it, but I think the awareness is increasing at the upper strata, not at the ground level. I think this has to be educated at all levels, especially in the school and the college, at the students level, right? Where they do not know what is happening to them, or where they do feel shy to express their inconvenience to parents or even within their peer groups. Unless we educate them about the symptoms, about the about its nature, about its uh, all the factors, how they could get affected when they miss to understand the symptoms, then only we could identify more cases. It was told that there's around 1.6 lakh affected people are there, but we have identified only 29,000. So this alarms because uh, more than a lakh people are not identified. Then the identified 21,000 are treated, but what about the rest? So we are in a critical position to provide more attention, to provide good treatment. We have to ensure the quality life for the affected. Quality life could be provided unless unless we identify them or provide awareness to them and proper diagnosis done and treatment started at the right time. I ensure that government of India is much interested in the progress and the prosperity of every citizen's life. Likewise, especially of social justice, keenly working on the quality life of every persons with disabilities. Um, are working, so we require everybody's support like SFI and other renowned organizations which is working for. We shall work together, walk together and win together for the benefit of the differently abled fraternity. Thanks for the opportunity. Jai Hind, Jai Bharat.
Thank you very much, Shri S. Govindraj, for sharing thoughts and vision for the disabilities community. And now I would like to invite on the dais Padma Shri Dr. P. Nalini to address our audience.
Good evening, everybody. At the outset, I, I salute the International Hemophilia founder, Ashok Maji, Hemophilia Federation of India, who struggled to bring in, I've seen him do it, how to bring in, but for them, we wouldn't be here. Many of you know him personally. For hemophilia, he thought about all the people. Without him, we wouldn't be here today. Another, now I'm glad that all the youth are coming up. This is what we want. Hemophilia youth to come up and take up the Hemophilia Federation on their shoulders and work for it. Another thing I wanted to say was, this year, you may talk about my national award about 2 years ago, but this year, in the Divyanjan category, Dr. Suresh Hanagawadi has got a national award for working for hemophilia. Let's give him a clap. Another important youth, I do not know him personally, but I follow him on social media, Siddharth Saha, belonging to which chapter I am not very sure, one of the eastern states, has got Guinness Book of World Records. He's entered Guinness Book of World Records for his artwork and decoration work which he has been doing. This is another. I follow all this youth on social media. I may not meet everybody. I want to keep myself updated, so I follow on social media. One important thing I wanted to talk about was prophylaxis. I'm thankful because not all the states are able to bring in prophylaxis. Few states have been able to adopt prophylaxis for children, Libra. Now, for adults also, Pitusura has been found to be, a trial done at CMC Vellore has found to be very effective. Some of them even forget they are hemophiliacs. They require even once in 2 months or 3 months, once a month, once in 2 months. It has been approved by American Association that also can be brought in, there will be no hemophilia. Hemolibra, some of the states are able to provide for their children, and some young adults. Telangana, even up to 25 years, they have been giving. Kerala has been, for 300 children, they have been able to give. All states are able to do it. NHM can help us to bring this about, prophylaxis. Go a great way in saving these children. There will be no Divyanjan after that. There will be no deformity. They will be able to do physical exercise. They will be able to even run, have normal life. So that we will prevent the deformity. Another thing, that hemophilia has been included into the deformity, special category of Divyanjan, that we are able to get many students into medicine. Now there are a lot of hemophilic children studying medicine, and they will all become doctors, and I am sure they will take up the cause of hemophilia. Then I think doctors like us, Dr. Vijay Kumar is here, like us. He has also received lot of awards. So people like us need not struggle. The hemophilic doctors themselves will look after all the hemophilia patients. That is what I think. That is my dream to come in future. I appeal to NHM to help us out in this prophylaxis, because it is of great help, and it has been found that the cost of buying factor really comes down, and also patients, they will be without deformity. So thank you very much for giving me an opportunity to speak.
Thankful to the Hemophilia Federation of India for having me here. I feel humbled. मैं हिंदी में भी बोलूँगी क्योंकि बहुत से मेरे साथी होंगे जो हिंदी में भी सुनना चाहेंगे. तो मैं 30 साल फौज में रही हूँ और पिछले 10 सालों से सर गंगाराम हॉस्पिटल में हेड ऑफ हेमेटोलॉजी हूँ, जो DNB सुपर स्पेशलिटी क्लिनिकल हेमेटोलॉजी प्रोग्राम चल रहा है उसकी भी हेड हूँ. आज हम इस जगह पे पहुंच गए हैं. मुझे याद है 1990 में जब मैंने MD ख़त्म की थी तो हमें थ्रोम्बोप्लास्टिन रैबिड ब्रेन या ह्यूमन एक्सीडेंटल केसेस के ब्रेन से बनाना पड़ता था, और APTT के लिए हमको कियोलिन को बीकर में डाल के बीड्स डाल के हिला के PTT के टेस्ट करना पड़ता था. उसी पे हम मिक्सिंग स्टडी करते थे, उसी पे हम और सेमी लॉग पेपर पे मैनुअल APTT उससे आज की डेट पे हम यहाँ आ गए हैं कि इस देश में हमारे पास फैसिलिटी आ गई है, अवेयरनेस आ गई है, क्योंकि मैं एक हेमेटोपैथोलॉजिस्ट हूँ बेसिकली. अवेयरनेस आ गई है कि डायग्नोसिस हो रहा है. अर्ली डायग्नोसिस सबसे ज़रूरी है. बड़े बड़े शहरों में तो हो रहा है, पर छोटे जगहों तक भी ये बात पहुँचनी चाहिए. क्योंकि मुझे याद है प्राइवेट हॉस्पिटल में ज़्यादा पेशेंट्स नहीं आते, वे चाहते हैं जो दवाई ले रहे होते हैं. पर हमारा एक गार्ड था बिहार से फौज में, तो हमने बहुत काम किया. 1999 में मैंने पूरे SS सेट किया आर्मी हॉस्पिटल में. वहाँ कोई प्रॉब्लम नहीं थी. गंगाराम हॉस्पिटल में गार्ड था और वो अपने 17 साल के लड़के को लेके आया जिसका नी खराब हो चुका था. पहली बार 17 साल की उम्र में उस लड़के का हीमोफीलिया का डायग्नोसिस हुआ, और सीवियर हीमोफीलिया था वो, और फिर उसको हमने थेरेपी पे डाला, पर वो लेट था. तो हम ये चाहिए कि इतनी अवेयरनेस हो जाए कि पता चल जाए कि हीमोफीलिया का चांस है. टेस्टिंग की फैसिलिटी बहुत सैड है कि हर जगह PT अवेलेबल है छोटे से छोटे हॉस्पिटल में. मैं अमृतसर मेडिकल कॉलेज गई, वो PT करते हैं, CBC करते हैं, APTT नहीं करते. वो कहते हैं जी बाहर के लैब को भेजो. APTT का सैंपल बाहर के लैब में जाता है, फैक्टर 8 लेबाइल फैक्टर है. फॉल्स फैक्टर 8 डेफिशिएंसी आ जाती है, जबकि असल में वो 9 होगा। ये सब चीज़ें एपी टेस्ट सही समय पे सही टाइम पे कैसे सैंपल को ट्रांसपोर्ट करना है, ये सब चीज़ें अगर अवेयरनेस फैलाएं और एक एक आप में से 10-10 को बताएं हीमोफीलिया के बारे में, तो अवेयरनेस हम लोग अपने सब्जेक्ट में अवेयरनेस जानते हैं, पर मैं खुद देखती हूँ कि हमारे ही डॉक्टर्स जो एमबीबीएस करके कहीं आते हैं उनको कोई समझ नहीं होती। और ये समझ हीमोफीलिया, थैलेसीमिया, सिकल, सारी डिजीज़ेस की, क्योंकि मेडिकल कॉलेजेस में भी इम्पोर्टेंट दी जाती है जो बड़ी बड़ी बीमारियां हैं, कैंसर है, कैंसर का थेरेपी है, हेमाटोलॉजी में भी क्लिनिकल हेमाटोलॉजिस्ट ट्रांसप्लांट करना चाहते हैं सारे। हीमोफीलिया जैसी बीमारी की तरफ जिसमें इनकम कम है, प्राइवेट में लोग कम जाते हैं। ये अवेयरनेस क्रिएट कराना, एंड आई एम सो हैप्पी कि अब नए नए ड्रग्स आ रहे हैं। एक ज़माना था तब हम ऐसे करते थे, आज हमें अपने टेस्ट मॉडिफाई करने पड़ रहे हैं, क्योंकि हमें इमिसुजमैब के लिए अब क्रोमोजेनिक फैक्टर ऐसे या बोवाइन फैक्टर ऐसे करना पड़ेगा मॉनिटर करने के लिए इनहिबिटर्स। पिछले साल हमारा पेपर पब्लिश हुआ है, हमने रोटम पॉइंट ऑफ केयर से हीमोफीलिया इनहिबिटर्स, सीवियर हीमोफीलिया, माइल्ड मॉडरेट हीमोफीलिया का डायग्नोसिस सिर्फ एक एक्सटेम पे करके हमने इंटरनेशनल ब्लड रिसर्च में वो पेपर पब्लिश किया है कि वो भी यूज हो सकता है पॉइंट ऑफ केयर जाके। बहुत काम करना है, बहुत हो चुका है, और बहुत मंजिल पाने के लिए कि एक भी हीमोफीलिया फिर डिजीज़ ना रहे, सिर्फ एक डेफिशिएंसी रहे जो करेक्टेड रहे और इंसान बिल्कुल ठीक ठाक रहे पूरी लाइफ, कोई डिसेबिलिटी ना डेवलप हो। इट शुड नॉट बी a disability, it should just become a deficiency which has been corrected. ये अगर अचीव कर पाएंगे तो दैट इज़ द बेस्ट। और उसके लिए आप लोग जो सब कर रहे हैं, बैठे हुए कर रहे हैं दिग्गज, मैं तो बहुत छोटी सी एक वर्कर हूँ हेमाटोलॉजी में, तो फ्यूचर बहुत अच्छा है। और अभी नॉन फैक्टर जो आ रहे हैं, क्लिनिकल ट्रायल्स होते हैं, यूएसए में अप्रूव्ड है, इंडिया में आना, डीसीजीआई अप्रूवल लेके डाटा देना, सो दैट जैसे वो कह रहे थे कि एनएचएम वाले उसको फिर शायद गाइडलाइंस में डालें, खर्चा भी देखना पड़ता है उनको एनएचएम में, पूरा एनएचएम का बजट एक डिजीज़ में शायद नहीं डाल पाते वो। पर अगर हम लोग मिल के अर्ली डायग्नोसिस, प्रोफाइलैक्सिस, ऑन डिमांड जो भी है, कई बच्चे हैं जिनको ऑन डिमांड भी नहीं मिल रहा है इस देश में, उससे आगे, जबकि गवर्नमेंट ने इसको ईडीएल में डाल दिया है, एसेंशियल ड्रग लिस्ट में आज की डेट में फैक्टर 8 भी है, नोवो 7 भी है, एक्टिवेटेड फैक्टर 7 कंपनी नाम से हम नाम नहीं लें तो बेटर है, और साथ में फीबा भी है, पीसीसी कॉम्प्लेक्स भी है। तो अगर ये सब चीज़ें ईडीएल में आ गई हैं एनएचएम के थ्रू, और बहुत ब्राइट है। ये नए ड्रग्स जो नॉन फैक्टर्स हैं, आप किसी का थ्रोम्बोसिस की टेंडेंसी बढ़ा दीजिए तो हीमोफीलिया ब्लीड नहीं करेगा, वो भी चल रहा है। क्लॉटिंग की टेंडेंसी बढ़ा देंगे तो ब्लीडिंग कम हो जाएगी, या हमको बाईपासिंग एजेंट्स, बहुत कुछ है, वो ओवर द नेक्स्ट 2 डेज डिस्कस होगा। तो फ्यूचर है, सब मिलके अगर काम करेंगे तो हीमोफीलिया के लिए बहुत किया जा सकता है, और हो रहा है और होता रहेगा।
For addressing our gathering here. I will now like our management kindly facilitate our distinguished guests for the evening. I would like to request our President Shri Palwa to kindly facilitate our chief guest for the evening. I will now request our Vice President Development, Shri Ramu Gadkar, Dr. P. Nalini. I now request our Vice President Finance, Shri Jagdish Sharma ji, to kindly facilitate Dr. Colonel Jyoti Kotwar. I will now request our Vice President Development, Shri Ramu Gadkar, to kindly come on the stage and deliver a vote of thanks to our distinguished guests.
थैंक यू वैभव जी। नमस्कार, आवाज आ रहा है पीछे? यस। डॉक्टर गोविंद सर ने कहा वो दिन दूर नहीं है, मैं भी कहूँगा सही में वो दिन दूर नहीं है, क्योंकि 6 महीने पहले पुणे में सर को मिला था डिसेबिलिटी प्रोग्राम के अंदर, तभी सर को इनविटेशन दिया था मैंने कि सर हमारे IHC 9 प्रोग्राम में आना है, तो सर ने तभी हाँ बोला था। तो मैं बहुत बहुत धन्यवाद कहना चाहूँगा सर का, डॉक्टर गोविंदराज सर का, कि हमारे इस प्रोग्राम में आकर उन्होंने डिसेबिलिटीज़ के लिए जो हमारे लिए वर्ड दिया हुआ है, मुझे लगता है, मुझे विश्वास है उनके टेन्योर में ये सक्सेस हो जाएगा और हमें डिसेबिलिटी के जो राइट्स है वो डेफिनेटली मिलेगी। मुझे बहुत सारा विश्वास है और सर से उम्मीद भी है। थैंक यू सो मच सर, आप यहाँ पे आ गए और हमारे प्रोग्राम को 4 चांद लगा दिए। जो अपने जीवन में हर एक कठिनाई से टकराते वही विकास के पथ पर आगे बढ़ जाते हैं। ऐसे डॉक्टर नलिनी मैम ने कहा कि हमारे बहुत सारे हीमोफिलिक्स आज डॉक्टर्स बने हैं, इंजीनियर्स बने हैं, बड़े बड़े इसमें क्षेत्र में आए हुए हैं। तो डॉक्टर नलिनी मैडम जो यूथ को एंकरेज करते हैं, उनका भी मैं बहुत बहुत धन्यवाद कहना चाहूँगा। उन्होंने हमारे आज प्रोग्राम में आकर पूरा बहुत सारा मार्गदर्शन किया। मैं धन्यवाद कहना चाहूँगा हमारे प्रेसिडेंट प्रेम रूप सर का, जिन्होंने विजन और मिशन के बारे में आपको बताया और उस मिशन और विजन को लेकर NHM के सभी डायरेक्टर्स डॉक्टर्स यहाँ पे आए हुए हैं। मुझे विश्वास है हमारे प्रेम सर के जो विजन है उसके तहत आप उस विजन को सफल करने में हमें बहुत सारा योगदान देंगे। आप सभी जो सभी स्टेट से आए हुए NHM के जो डायरेक्टर्स है, डॉक्टर्स है, आप सभी का भी मैं मनपूर्वक धन्यवाद करना चाहूँगा 2 दिन का इस प्रोग्राम आपको अटेंड करने के लिए। आप सभी का भी धन्यवाद। आज डॉक्टर कर्नल ज्योति मैडम भी हमारे साथ में है, उन्होंने उनका दौर आज हमें बताया, उस दौर में क्या चलता था और अभी अपडेटेड सिस्टम क्या आया हुआ है, तो उसके लिए भी मैं डॉक्टर मैडम का भी बहुत बहुत धन्यवाद करना चाहूँगा। हमारे सभी मैनेजमेंट टीम, जगदीश सर, डॉक्टर सुशील सर नहीं आए, उनका CEO मैडम, और यहाँ पे उपस्थित हमारे सभी EC मेंबर्स और चैप्टर के की पर्सन जो हर डॉक्टर्स को लेके आए, सभी का मैं मनपूर्वक धन्यवाद करना चाहूँगा। स्पेशल थैंक्स कहूँगा रोश फार्मा, टकेडा, फाइजर, बायर कंपनी, अल्फा ड्रग्स और क्रिटिकेयर, नोवा नॉर्डिक्स, इन सभी फार्मा कंपनीज का भी मनपूर्वक धन्यवाद कहना चाहूँगा। थैंक यू सो मच।
Request our management to kindly escort all our dignitaries. We will now proceed with our now like to invite on the stage Dr. Vijay Shah from Surat, Gujarat. Dr. Vijay is a pioneer in the hemophilia care in Gujarat. He will be briefing us about
in the state of Gujarat. In the state of Gujarat.
Gujarat is a rapidly progressing state with a population of 7 crore 35 lakhs, which has 34 districts. All the districts have a different population. Dang with 2.28 lakhs and Ahmedabad 72 lakhs. So there is varied population in the different districts. It is the largest coastal area in India. It's 1,600 kilometers. Gujarat has a hill, there's a desert, there's a forest, and lots of tribal population too. World's tallest statue, you'll see in Gujarat, Statue of Unity, and two businesses, they are flourishing, diamond and textile, they are the world hub. You see only Asiatic lions in Gujarat only. Coming to the hemophilia in Gujarat, we know that prevalence of hemophilia is 1 per 10,000 population. So coming to 7 crore 35 lakhs population, we'll expect around 7,350 hemophilics in Gujarat. As on today, in 6 different societies of hemophilia, we have enrolled about 2,400. So still there is a long way to go. We have to find out approximately 4,900 missing hemophilics even today. These are the different hemophilia societies. As I told you, there are 6 hemophilia societies or hemophilia chapters: Ahmedabad, Rajkot, Vadodara, Surat, Mehsana and Bhavnagar. Ahmedabad was the first chapter which was established in the year 92, and latest is the Mehsana and Bhavnagar chapter just before COVID in 2019. And the others are the names of the president, vice president, secretary and key persons of all the chapters. Coming to the total number of the hemophilics enrolled, total 1,982 A patients are enrolled, 266 hemophilia B patients are enrolled, 82 von Willebrand disease patients are enrolled with these 6 societies, other 70 coming to total 2,400. Maximum number of the patients which are enrolled is at Rajkot. They have enrolled 653 patients, followed by Surat, 650 patients. This is very important. The budget is most important when it comes to hemophilia. We all know that factors are very costly. We need more and more budgets. Gujarat government has a separate budgetary allocation for the patients of hemophilia starting from year 2012. It was in the year 2012 for the first time there was a budgetary allocation the tune of rupees 2 crore separately for patients of hemophilia. It was a great move at that time, the government of Gujarat, to have this separate budget allocation. And since then, every year this budget has increased. And you can look into this in 2025, it has gone to 150 crore. Such a large budget is separate for hemophilia. This provision is there in our Gujarat government's annual budget. Coming to the procurement, in Gujarat there is a Gujarat Medical Services Corporation Limited. They in fact invite tenders for all these factors, may it be standard of life, may it be extended of life, may it be non-factor therapy, emicizumab or von Willebrand disease or factor 7, FIBA, etc. So there is a centralized tender which is invited, and all the hospitals, they will send their requirements depending upon the patients coming to those hospitals, and they will add something extra also if they feel that they will be able to find out more patients, coming to the total and accordingly that requirement is put forward, will go to the health department. From health department it will go to the GMSCL, and then GMSCL will purchase it and give it to the hospitals. So this is how it works. Or a non-factor based therapy is available. This is the list of the hospitals. Maybe a medical college hospital or a district hospital. There is one Hemophilia care center which runs 24/7 at Surat. I will give you detailed later. And there are Hemophilia daycare center. There are 4 centers. Sola, one is at Gotri, that is Baroda, Nagar, and Dharpur. Dharpur is a Patan. In Gujarat, start with, from 2012, recombinant factor is used. Unless recombinant factor is not available, then and then plasma derived. Otherwise, to start with, recombinant factor. Now, a non-factor based therapy is also available. Long-acting factors are also available. Recombinant factor 7 and FIBA is also available. Standard half-life factor is also available. Non-will brain disease factor and antifibrinolytic agents are used. What are the benefits for the patients of hemophilia? All these factors and non-factor based therapy like emicizumab, they are given free of cost, no charge, totally free. It is given on demand, but gradually prophylaxis, it has increased so many. It has increased so many. This now coming to the factor 8 and factor 9 assay. The laboratory is very important. Factor 9 and factor assay, 8 assay is available at Ahmedabad, Surat, Vadodara, Rajkot and Bhavnagar medical college hospitals. Of course, in a private laboratories, it's always available at guideline for the management of the patients. What is the dose to be given, etc. And almost all the centers have a physiotherapy is to be treated by standard half-life factor 8 or standard half-life factor 9. In Gujarat, there is a very good liaising between the patients, the doctors, healthcare staff, Hemophilia Society. In fact, Hemophilia Society is so proactive in Gujarat that we at Surat Hemophilia Care Center, there is always one or the other member of this society is present, and they facilitate the patient's management along with the staff, along with the doctor of the Hemophilia Care Center. There is a very good liaising between the government and society too. These are the few of the photographs of the different societies, and the activities are them. Ahmedabad chapter. So all this chapter are doing wonderful activities. Into the Hemophilia Care Center, New Civil Hospital, Surat, which is a 24/7 care center, was established on April 24, 2015, and it's like a model center for the state. It's situated in approximately 2,200 square feet area, a reception cabin, manager office, consulting room, 5-bed patient ward, nursing room, counseling room, physiotherapy ward for the patients of hemophilia. And say in the evening 5, they send data to the government of Gujarat, and just at a click they get all the data and they send it. You can ask any data, you can get it immediately. This is also very important that because it is doing such a wonderful work, a separate terminal for issue of the case paper. We all know that in a government hospital, whenever we want to go and show the patient, we have to get the government case paper. So a separate terminal for issue of the case paper is there for the patients of hemophilia. So it is there at a hemophilia care center. Staff. And this is the photograph of the hemophilia care center. You can see the lounge area, then laboratory, manager office, all the surgical procedures are also done. Until date, 30 major surgeries are performed and approximately 60 minor surgeries are also performed. First successful hip replacement surgery, head of the Department of Orthopedics, Shri Hari Menon and his team. The first hip replacement surgery done in India on the patient of hemophilia. They are now very confident in operating any type of the patient. They remove pseudotumors. Neurosurgeries are also done. Cesarean section is done. Knee replacement, abdominal orthopedic surgeries and dental surgeries. And you can see a lot of importance to such type of the work. And that's how hemophilia patients' knowledge is promoted. Like people know about the hemophilia in detail and what a government and a hemophilia care center is doing. These are the few guest visits at our center. Ambassador of Nepal, when he came to Surat, he came to know about this center and came to visit us. Anu Agarwal, she is a Bollywood actress. She herself is a big philanthropist, run her own NGO. She also came to visit our center. Our MLA, Shri Harshbhai Sanghvi, he is at present Home Minister of Gujarat. He also visited the center. It is just by words it has spreaded and they came to know about the center and came to see it. WFHI Women's Group President Sonal Sakari also visited. I told you about Sri Kumar Bhai Kanani, our ex-health minister, Punesh Bhai Modi, MLA, even Prem Rupalwa came last year, and Ramu Bhai and Dinesh Bhai Vadaria, our been visited by
Ramuji to kindly come on stage and facilitate. Moving forward, I would now like to invite Dr. Poswal, Professor Pediatrics, State Medical College and Hospital. Dr. Poswal is not just a senior doctor, he is also a friend of the hemophilia community. He will be briefing us about the advantages of integrated center for hemophilia.
Thank you, Vaibhavji. Chief guest of this program, Yash Govindji, the Disability Commissioner, Government of India, has showcased the state of Gujarat. He has shown the Asiatic Lions and the Statue of Unity. And I will talk about unity and integration for three common chronic blood disorders, that is hemophilia. Hemophilia and hemoglobinopathies are the serious genetic blood disorders, and they need lifelong treatment. If undiagnosed and untreated, patients with the hemophilia, sickle cell disease and die. So there is a importance of early diagnosis and a very, very integrated care. So hemoglobinopathies are the commonest genetic disorders. It is estimated that the 7% of the world's population carry abnormal hemoglobin gene. So if we think of thalassemia, around 2000, he has said that the hemophilic patient in India is more than 29,000 diagnosed cases. As Dr. Vijay has highlighted, lots of patients are, and Dr. Nalini has highlighted, lots of patients are undiagnosed. Similarly, in the world, around 4.65 lakh people are there with hemophilia, including hemophilia A, B, von Willebrand's disease, and other similar disorders. The most unfortunate aspect of hemophilia is that 94% of the people living with hemophilia develop disability. It is the disease which, if diagnosed early and proper prophylaxis is given, the disability can be prevented. This is the most unfortunate part, that they develop disability, and as the age advances, the disability keeps on increasing. So we are very, very backward in the prophylaxis for hemophilia. Joints, they develop target joints and disability. If we compare our prophylaxis with the other developed countries, in our country only 9% of the patients of hemophilia are on regular prophylaxis, as compared to the developed countries where around 90% are there on prophylaxis. Now about the sickle cell disease, it is mainly seen in the tribal people of world. In our country, it has been thought that out of the 7 crore patient, which is to be screened in the 3 years under our national sickle cell elimination mission, which our Honorable Prime Minister launched in July 2023, it is seen that the prevalence is different in different areas and different studies, ranging from 5 to 40%. So it is the commoner disorder as compared to thalassemia, but because thalassemia is given a lot of emphasis, sickle cell disease was neglected for many years. But since cell elimination of India under its mission sickle cell elimination is going to roll out this program in all the states of the country and in all the union territories. So it is seen in non-tribal population too. It is very, very important, and that is why I want to emphasize it, that while talking of the integration of care of these 3 common disorders, you may think that sickle cell is limited to certain parts of the country only, certain population groups only, seen in the non-tribal people also. So after 3 years, in the phased manner, Government of India is planning to launch this program in the other states and union territories also. By 2047 means 100 years. By 2047 means 100 years of independence of our country. And this is taken in the mission mode. Our Honorable Prime Minister launched this program. And in this 7 crore people under the age of 40 years are to be screened. People under the age of 40 years are to be screened. And it's a good news that most of the states have achieved 70% or 80% target. In our Rajasthan state has achieved 90% target of screening the target population. For thalassemia, the National Health Mission supports the states and union territories to strengthen the healthcare system, including support for healthcare system, including support for prevention of flu. They all are together to support states for prevention and management of thalassemia. Now, similarly, the NHM government of India, they support for the early diagnosis, screening, and management of hemophilia. And because health is a state issue, so different states have different allocations in the budget for management of hemophilia and early diagnosis. Now I want to emphasize that why there is a need for integration. The three programs for three major chronic blood disorders are running parallel. At some places there are good services for hemophilia patients. As Dr. Vijay Shah has shown in Surat, it's a wonderful hemophilia comprehensive care, I would call it, not hemophilia treatment center, it's a hemophilia comprehensive care. Similarly, I talked to Dr. Vijay Kumar and his team from Kochi. They are having very good hemophilia comprehensive care center and even recreational activities. They are having swimming pool in the waiting area so that the children can come and they can have a fun over there. There is no fear of the hospital. So at different places there are different status of these different status of these three disorders being taken care of, and level of services are provided for, hemophilia, sickle cell disease, and thalassemia. Hemophilia, sickle cell disease, and thalassemia. Whereas the services, if you see in this, all these three disorders, we require hematologist or a pediatrician and physician. We require hemophilia and surgical nurses who are trained. We require social workers because there is a lot of psychosocial issues with the patient, chronic blood disorder patients. Children have a lot of pain while coming to hospital and getting packed RBC transfusion, hydration, injectables, if the patient develop infections, especially in sickle cell disease, factor infusion. So a lot of pain is there. So the children develop depression and the family also suffers a lot. So that we need a very good social support. And I would congratulate all the three organizations, especially the HFI, the NASCO, and Thalassemia Federation to support the people living with these blood disorders. So we need psychologists to support the patients when they have orthopedic and general surgery, maternal. So to care for the women during screening of patients who are having signs and symptoms suggestive of sickle cell disease is done, and it is on the mission mode. We are very, very successful in that. But for thalassemia and hemophilia, there is no such mission going on for early detection, for the premarital counseling, premarital testing, antenatal counseling, prenatal counseling. That is why if we combine the programs of all these three chronic blood disorders, the services provided for all these three chronic blood disorders, I think they will complement to each other and every patient will be benefited. So where is the gap for integration in hemophilia and hemoglobinopathies? So at many places the departments are not well integrated because it is a multidisciplinary team which works for all these three disorders. Lack of integrated diagnostics. The coagulation labs are not there. There's only one inhibitor lab in entire state of Gujarat, that is at Ahmedabad. I would suggest that every medical college should have factor assay as well and growth monitoring and prevention of the transfusion transmitted infections. The things are there but not integrated, like in some centers, physiotherapists are there for hemophilia patients, not for the sickle cell disease patients. So we need to integrate the common services for all these chronic blood disorders. Counseling needs to be improved across all these three disorders, because it is the counseling which will bring change in the early diagnosis, in the screening, in the sickle cell elimination mission. Our ASHAs are given maximum emphasis. ASHAs, because they go home to home. So training is imparted under the Dharti Abha program. Training is imparted to ASHAs so that they can go from home to home and they can sensitize the people, they can counsel the people to come forward for the screening and for the testing. And they emphasize on the adherence to the treatment also. So this is how the integration of hemophilia and hemoglobinopathies can be done. We need to organize workshops for identifying opportunities and unmet needs. Select in the selected districts and medical college levels. We need to develop, assess, and questionnaires for all these three chronic blood disorders to identify who should be tested. Awareness raising in selected districts by ASHA workers. Equip joint hemoglobinopathy and hemophilia clinics. Pilot point of care, because for sickle cell, the screening was done by point of care testing. So similar point of care testing, some point of care were including thalassemia also, some were not testing for thalassemia. So there should be a standardized uniform point of care testing so that there can be screening for thalassemia and can be there for the hemophilia also. Training for healthcare professionals in the selected hospitals where the load of these disorders is more. Monitoring and evaluation framework, and there should be a national blood disorder meeting. So now the SWOT of our Rajasthan state, the strength of our state is that we have a state nodal officer separately designated for blood disorders. Dr. Ranawat is here, Dr. Mahavir is here. The state funding is available for hemophilia, thalassemia, separate for three disorders. We have our own printed case diaries. We give not tested blood for thalassemia patients, and whenever required for the sickle cell patients also, to prevent the transmission of transfusion acquired infections, especially HIV and hepatitis B. Hemophilia surgeries are being conducted in our state. One center is there for Center of Competence, which is R&T Medical College, Udaipur. AIMS Jodhpur is a center of excellence. We have a largest experience of screening for hemoglobinopathies. In our center at R&T Medical College, Udaipur, we have screened more than 25,000 newborns. So every newborn born in our center is screened for hemoglobinopathies. We take a dry blood spot and then we go for HPLC to detect whether there is a sickle cell hemoglobin variant in that sample or not. And later at 6 months we confirm it. Similarly, we screen all the women in the antenatal clinic, and if a woman is found to be having sickle cell disease or even carrier, thalassemia or even carrier, then her partner is also tested, and if both are positive, then we counsel the couple for the possibility of child born with the homozygous state, with the disease state. And this is how this screening of every newborn and every pregnant woman has improved early detection, and it will help in the national sickle cell elimination mission and even decreasing the prevalence of thalassemia also. Our weaknesses are the departments still need to be more integrated. There is a lack of uniform diagnostic facilities, lack of prophylactic services. Our hemophilia patients, only few patients are having regular prophylaxis. Most of them become on demand, their disability. There is lack of accuracy of point of care testing, which I already mentioned. Things are there but not integrated. I already mentioned counseling needs to be improved across the three disorders, because the counseling is the most vital part of elimination and prevention of the diseases. So in our country, most of the centers are not having psychologists, not having physiotherapists. Physiotherapist for some center I think is usually there, but the psychosocial workers, counselors, they are not there in most of the, where when the women come, they should be screened, and if found positive, then the cascade screening of the entire family should be done. And this is how we can prevent spread, or you can say the transmission of an affected, transmission of this disease in the affected sibling, newborn. So opportunities, we need to develop centers in all the medical colleges with clear SOPs, reach more stakeholders like you. Facility for chorionic villus sampling, pre-implantation genetic testing shall be available at more places. So the potentials for shared services, integrated care of hemophilia and hemoglobinopathies that we has seen in the centers at Gujarat also, we need centralized registry entry. And it is a very good initiative by Government of India that in the same sickle cell portal, the entry of data of the hemophilia is also done. Similarly, I would suggest that the entry of data of thalassemia should also be done. So it can be a nurse or a social worker who can assist, is very, very vital, and counseling. The counseling should never be that authoritative and that negative psychological psychological impact on the mental health of the patient. So while doing the counseling, the regular consultations with the healthcare professionals specialized and trained in the bleeding and blood disorders, the blood storage centers where they are not there, transfusions should be improved, exchange therapies should be improved, exchange therapy, especially in the sickle cell patient, should be improved, and cryo should be made available where there are patients as mentally and socially when a child is having any of these three chronic blood disorders. So we need to have more and more, either the patient parent organizations like NASCO and HFI to support these patients. Physiotherapy services for hemophilia as well as for sickle cell disease are very, very important. Joint awareness raising for emergency department, other departments wherever Parliament, Honorable MLA, our NASCO Secretary Mr. Gautam Dongre, our Superintendent. This is when there was a visit for the Integrated Care Center at Udaipur to see Mr. Prem Alva, Mr. Dharam Singh, Mr. Lalit, Mr. Gautam, the Noah Nordis people, Mr. Babulal Purohit. They all were there to discuss about the integrated care model in our state. And this is a workshop was organized at Jaipur, again supported by Noah Nordis, where Mr. Cecil Ross was there, Mr. Prem Alva, Mr. Mahavir, Mr. Gautam Dongre, even from Assam there was a team led by Dr. Anupam Datta, and we had a lot of deliberations how to implement the integrated care for chronic blood disorders in our state and in the state of Assam also. We organized a lot of training sessions for the doctors, for the nursing officers, for ANMs, and even for the ASHA workers on raising the awareness about the diseases. And this is a true example of the integration. This is a girl with thalassemia, and in the middle one, Mr. Dharam Singh with hemophilia, and Mr. Lalit with sickle.
For our next session, now like to invite Dr. Rahul UR, State Nodal Officer, Blood Cell, Government of Kerala. Rahul will be taking us through the access for care for PWH and procurement and the distribution plan for AHF for the state of Kerala over the next 15 minutes.
Good evening, everyone. Good evening, everyone. First of all, I'd like to thank HFI for this opportunity. So, this is my third IHC actually. So the first IHC was actually a learning process because that was soon after I took over the charge of State Nodal Officer for Blood Cell. So I was like a new kid in the block trying to understand what is happening across the country. In the last IHC, it was soon after the implementation of Hemophilia prophylaxis for children less than 18 in the state. So it was a very proud and happy moment last year. This year actually, I had two plans to be implemented prior to this event, but we have a state update coming next days, 18th and 19th, so that will happen only after this event. So one of which is the declaration and release of the guidelines for management of women and girls with bleeding disorders in line with the theme of this year's World Hemophilia Day. So coming to the state program, as earlier discussed regarding Gujarat and Rajasthan, there are wonderful models and many things to be learned. That is the peculiarity of this program, that we have a lot of things happening in silos in many parts of this country. But we do not have a common thing which is wonderfully implemented across the country. That is our long-term aim, and I always see one country, one treatment in all these IHCs. We are still trying to reach there, and that will be one of the ultimate achievements of the entire community. So coming to our state program, the state program is titled Ashadhara. Ashadhara, when translated, it means the ray of hope. So this program is actually an integrated program for management of hemoglobinopathies and hemophilia. So I would like to, last year also I had the similar topic, but this year I would like to focus on where we stand, where we stood, how we moved forward, and what lessons can be learned and tried to be implemented in other parts of the country. Long-term ambition of one national protocol, national guideline across the country. So this basic details about the state. When compared to other previous states mentioned, our population comes to around 3.34 crores comparatively. On a lower side, the gender distribution is almost similar, with female 1.7 crore more than the male population. So these are some of the basic details, and I would come to the challenges of the state in particular. So as you all know, we have a rising burden of NCDs in the state. We have the life expectancy has improved. There is an aging population. There is brain drain. There is migration of labor force. So we have a more of aged population in the state, and we are on another side of the demographic pyramid. And one of the major concerns when it comes to hemophilia management is to know about the macroeconomic trends and the real economic scenario of the state, because that is where the adoption of the recent or the advanced therapies, the novel managements, the non-factor therapies or the gene therapy is actually dependent on the actual economic and financial stability and sustainability of a state. So Kerala's economical and financial challenges is comparatively high when compared to other states, because we are one among the 5 highly stressed states with high indebtedness across the country. So at this point, that is where the state actually stands, and from there we have to come up to a program where we intend to provide the best possible treatment to the most of the patient community. So when the Ashadhara program was launched, prior to the launch of the program, what was the situation in the state is the major point. So major thing is regarding the capacity of our health system. As Dr. Poshwal had mentioned about Alua, the Cochin Hemophilia Treatment Center, run by Dr. Vijay Kumar, he himself is here. So that center was one, one unique center, whereas apart from that, many other centers were lagging behind. So we had one center which is a model, but our entire program is designed in such a way that a system is established and there is a health ecosystem wherein more such centers are developed across the state. Today we have, across the 14 districts, 17 hemophilia treatment centers, including the medical college centers, and there are 3 more centers yet to come in this year. So that was one key area that we focused on, how to establish newer centers and how to improve the infrastructure and facilities so that the health system is sustainable on a long run. Now the second main component, and this is one of the key components, that is the data-driven program. So there was no clear-cut data of how many patients we have. So what is the actual prevalence of the condition? So we focused on development of an Ashadhara registry. That registry was actually containing the data of hemophilia, thalassemia, and sickle cell anemia. Of course, now sickle cell anemia we have shifted on National Sickle Cell Portal. Hemophilia data is also to be entered in that portal, but we still maintain the Ashadhara registry. Advantage of that registry was that we could make many informed decisions based on the data that we could compile based on that. And another thing was the introduction of a nurse coordinator for each hemophilia treatment centers and districts. So that was beyond the concept of a staff nurse delivering the nursing care. They were given an administrative role of involving them as a nurse coordinator into the scheme, which is practiced in many of the developed countries. So that is another component that was fit into the system, which had helped in the data collection, data updation, as well as establishment of the treatment centers to be implemented in a better manner. So the third area which we focused on was to assess the resource utilization. So what we see in a non-integrated or a non-data driven system commonly is that many of the hemophilia patients, not just in hemophilia, in any disease to say, many of the patients who actually require treatment may not get these resources, whereas these resources get utilized on a higher scale in particular small group of segments. So that is one area which again we can all address if we have a proper data-driven mechanism and daily updation of the data so that we get to know what is the actual factor utilization in the periphery for each individual patient. So that is one of the advantages that we had based on this registry. And one of the main component of this management of hemophilia or hemoglobinopathies prior to introduction of this program was little focus on the outcomes. So that is one of the key components, starting from the assessment of annual bleed rate to the each and every component that determines the quality of life of each individual patient and their caregiver. We need to focus on what output and what outcome we can bring in. That was described in the previous presentation also. A robust monitoring evaluation mechanism actually focused on the outcomes and outputs. And the last point, again related to the wasted resources or the duplication and fragmentation in care, that is resource utilization, the budgetary utilization is not following. So based on these health system challenges, we developed this program, and this was the first major key component of the program, the development of a data-driven mechanism. So as of now, we have around this actually has got updated. Nearly 3,500 patients having all these diseases, hemophilia, thalassemia, and sickle cell anemia. So we have a detailed record of district-wise patient details, which is again classified into hemophilia A, B, mild, moderate, and severe, and von Willebrand disease, other bleeding disorders, thalassemia, sickle, etc. So every individual patient gets a unique Ashadhara ID card, therapy in detail later. So it was basically something which was linked to costing and how much expense is involved in procurement to an outcome-based thing. So how we introduce this non-factor therapy based on an outcome analysis. That is what I would like to focus today. So state has a technical committee where we have hematologists and treating physicians who handle the hemophilia care in the public sector across the state. So what we actually assessed was the annual bleed rate, unmet clinical needs, and we actually identified patient cohorts like inhibitor positive patients with severe bleeding, children less than 18 years, then the geographical mapping of the patient list for adoption of the non-factor therapy. So initially it was very stringent, following only on inhibitor positive severe bleeding cases. So when in 2022, as I mentioned 2 years back when I joined, it was around 30 patients overall in the state who were receiving non-factor therapy. Now it comes around 350 plus. So that is the experience over the last 2 years. So this has also improved the adherence to the prophylaxis regimen. Earlier also there was prophylaxis with factors, but from there when it is shifted to non-factor therapy because of the ease of administration, monthly once or twice factor administration, etc., and lack of school absenteeism, work absenteeism, many factors which has led to increased compliance on the prophylaxis, which has definitely helped in the improvement of quality of life. And also there is a gross reduction in the indirect cost involved in the treatment as well. So this is how it evolved in the state. So November 2020, the first proposal for including the non-factor therapy was rejected in the state. From there, this entire journey had started, as I mentioned. So now 92% of patients registered in the scheme with inhibitors are on non-factor therapy. And less than 18 children, non-inhibitor patients 96%, and in adult population 20% of non-inhibitor adults are also on non-factor therapy. So this is the patient selection criteria. It is based on annual bleed rate, presence of inhibitor, venous access, the difficulty of venous access, the type of bleed, life-threatening, major and complicated conditions, chronic arthropathy, synovial hypertrophy, and as I mentioned, the geographical conditions and many other conditions leading to the access to healthcare facility. So based on non-factor therapy. Now, a health technology assessment process was involved in this to identify the patient archetypes, and the comparison and the cost analysis, a detailed cost analysis workshop for 2 days were conducted for adoption of the non-factor therapy. And of course, there is an innovative procurement model for reducing the drug cost. So this is the impact. So marked in blue is the factor adoption for prophylaxis, and marked in orange is the non-factor therapy. See, the graph has evolved over time. And comprehensive care center, apart from STC, where integration of other surgical departments and many other components can also be brought in, as mentioned in the Surat model. So that is one key area which we would be focusing this year. Next, enabling access to other innovative therapies. So the expansion of adoption of novel therapies is also in consideration. Then, of course, similar opportunities to be utilized to advocate for the cause and showcase what we have done, so that this learning helps in and is mutually benefited. And two other things which were in our KTIs with hemophilia, together we will and we can. Thank you.
I will request our EC member, Jimmy Manuel, to kindly felicitate Dr. Rahul UR. I would like to kindly request Dr. Sharma to kindly come on stage and address our audience.
Good evening, ladies and gentlemen. Distinguished guests, fellow healthcare professionals, colleagues, patients, their family, of course, the organizers. It is an honor to be here on the World Hemophilia Day. Today we come together not only to celebrate the strides we have already made in the diagnosis and treatment of hemophilia. I'll not speak much on the technical aspects of the disease because the speakers before me have already spoken at length about the technical issues. We have come a long way from times when hemophilia was cloaked in uncertainty. Advances in medical research and treatment options such as recombinant factor therapies had dramatically transformed patient care. However, these achievements represent only part of the overall story. The heart of our progress lies in the collective efforts of dedicated healthcare professionals, researchers, and community advocates who work tirelessly to provide not only cutting-edge treatment but also compassionate, holistic care to the patients. Since my residency days some 35 years back, things have undergone a sea change in the management of hemophilia. Awareness and early intervention, of course, remain critical. Educating both the public and the medical community has enabled us to identify hemophilia at the earliest stages, allowing for timely interventions that change lives for the patients. For our young patients, early diagnosis means fewer complications and a greater potential to lead healthier and more fulfilling lives. This progress reminds us that each step forward in our understanding of hemophilia is a step forward in empowering those who are affected by this. I want to emphasize the indispensable role of families and caregivers. Your unwavering support offers strength during challenging times and builds a community where every individual feels understood and valued. It is your dedication that reinforces our efforts in creating support networks and educational programs for our patients. As we look to the future, research remains the forefront of our mission. Our academic and clinical endeavors continue to push the boundaries of what is possible with the goal of not only managing hemophilia more effectively but also one day achieving a cure. A spirit of collaboration, clinicians, researchers and community organizations is the engine that drives the innovation of our field. Today on World Hemophilia Day, I ask each one of you to renew your commitment to this shared journey. Let us continue to work together to improve assessment to treatment, encourage early intervention and build robust support systems. Our combined efforts are more than just professional obligations. Thank you for your relentless dedication, for your partnership in care and your commitment to making lives of many. Together, let us remain steadfast in our pursuit of a future where hemophilia is not a barrier to living life to its fullest potential. A committed HFI supported by a dedicated team can make the impossible things possible and achieve the target. My best wishes to the whole team and all of you. Thank you very much, ladies and gentlemen. Thank you.
Request our EC member Shri Samar Singh ji. Now move forward the panel discussion call upon stage
Thank you very much, Mr. Vadu. So I would like to invite some state nodal officer for this panel discussion on streamlining health program implementation from PIP planning to procurement and distribution process. It's available in the agenda. So I would like to invite Dr. Sukhveer Singh sir, DGHS from Government of Haryana. If sir is there, otherwise the team of two other, yes sir is there, please come on the stage sir. Dr. Bobby Gulati sir, Joint Director, Government of Punjab and State Blood Cell in charge, and Dr. Amar Singh Nayak, Additional Director, Government of Telangana and Blood Cell in charge. Sir was there. Dr. Amar Singh sir. Yeah, okay. So, Persona ma'am is not there today. Dr. Hitesh, sir, Deputy Director, Government of Gujarat, by State Government. Dr. Hitesh, sir, and Dr. N.K. Gupta, sir, from Government of Bihar. They come on the stage. And Dr. Belua, from Blood Cell, Government of Tamil Nadu. There? Anybody from Tamil Nadu there? State government Tamil Nadu? Oh, yes, she's coming. Okay, very good. Welcome you all. Yes, sir. Please come on the stage. Officer from we have West Bengal, Dr. Nimai sir. Dr. Nimai Mandal. Thank you very much, sir, for coming here today. As we know, this is a very important topic. Kindly check your mic first. Your inputs are valuable. So let's start some of yes, yes. Haryana have good
Dr. Dr. Sahi from Jharkhand, IHC.
Bihar is dependent on NHM, but earlier it was dependent, not dependent, because it was included in our EDL. All hemophilia factor is included in EDL. So at that time we were not requiring fund for hemophilia in our IP. But this year we have demanded from NHM for hemophilia factors and non-factors. But I don't think NHM will approve for non-factor, but they will approve for factors only.
Earlier, as you mentioned, our Gujarat state is fully state funded running this program of hemophilia.
NHM funding for hemophilia. We are only talking about hemophilia here. For other things we understand, but it's Dr. Belvo, NHM also.
Yes,
take
ma'am.
part-
In
yeah.
Tamil Nadu, we are dependent on NHM and state.
State budget is
Yeah,
also
yeah.
there.
40 crore we get from NHM and
Okay.
20 crore in state.
Okay, okay.
From West Bengal,
West Bengal also
previously
take from NHM, sir, I know.
this hemophilia is mainly funded by the state budget.
Yes.
Recently, we have some central budget, NHM fund.
That's great. We wonderful that we have panelists type of states who are self-funded and who take support from central government. Since this development, everyone is aware of that now factors which have been included in national essential having some budget towards hemophilia, then they can divert it to other non-factor therapy which are not available under NHM, and take other support for factors which are under EDL from out of supporting all kind of patients. Stop giving medicines because of the first question is
To strengthen the hemophilia care, inclusion of non-factor medicine into EDL, which we have done in Bihar. So Bihar has done included Imisulimab in our EDL, and if it is included in EDL, it can be purchased through a state fund.
right, sir. So that's why we today we were expecting NHM policy makers to light on this topic that what they are going to do about it. But we are expecting them tomorrow, not today. We can we can talk to them about it.
As we have included in EDL, you should go for NLEM. Inclusion in NLEM. That will
NLEM
be
is by
easier for
Department
inclusion
of- yes,
for
sir.
our state.
Sir, actually NLEM is, so National List of Essential Medicines by Department of Pharma, they use it for policy that control of prices in the country. And NHM, they also they can drive their list of essential medicine from that, and they can have different priorities also. So some of the drugs which
Then another thing is that you can write a letter to a state government,
Yes.
as you have sent letter for APCC and DHL. Why not you send for that also?
we are NGO, we take people's voice, patients' voice to government so that they can make public friendly, patient friendly, state friendly policies. We can just raise the voice. The power is not in our hand, it is in your hand, because states have always have power. So you don't realize when, if somebody defending in PIPs, your proposal, nobody can say anything, because we keep on saying whenever some court case, some problem comes to central government, they always send it to state government and say health is a state subject. Though they are fully involved, they are making policy, making national guidelines and everything, but while coming to owning the responsibility, it's with the state. So therefore you have all the power to make your own guidelines, your own list of essential medicine, your own way of having things like Kerala, which is our very dynamic nodal officer from Kerala. He just explained Gujarat, how wonderful sir they are doing. So Dr. Vijay Shah just explained. Rajasthan, sir.
Accepted. All nodal officers are doing hard work
Yes,
for
sir.
this, but there is limitation to nodal officer also.
Okay,
But
sir.
we are ready to do in our state whatever I have capacity I can do. If you can do advocacy from NHM for inclusion in NLEM, all the state have will give got a grant space for inclusion of this medicine in their PDL. So there will be a good criteria for first and foremost criteria
Yes, sir.
for EDL is NLEM.
Right, sir. So, sir, despite having budgetary allocations, whether through central government, through state government, we are still facing
intervention center. Total number of cases they have very clearly. So because all the patients are treated under tertiary care center. So there is a mechanism. So NHM directly gets it from the DEAC. So they can very well have the line list, because total in a state you may have 2,000 to 5,000 cases. PIP, we requested for 10 crore. NHM will support for hemophilia factors.
Yeah, so despite NHM giving a significant support, financial support, mostly financial only, support towards hemophilia, there is more focus due to national priorities on other disorders. So we have to, that's why Dr. Lakhan sir talked about integrated care approach, because we know that we have limited, human resource in the state, limited, there's a maximum team of 2-3 people for blood cell, and sometimes they are given additional duties also. So how difficult it is to manage blood bank, the sickle cell, this and that and everything. And then we talk about quality in this. It's very difficult. So integrated care approach is a very good concept. Sir explained in detail also how they are managing. We also want comprehensive hemophilia care. So everybody wants comprehensive care for their disease. The panel, but I would like to invite you also, sir. Please. Since Maharashtra has been facing a lot of issues, especially in this PIP 2024 to 26 years, because as it was mentioned that tertiary care centers won't be funded, and most of the care towards hemophilia, because hematologists are there in medical colleges, we should have a self-sufficient good district hospital also. But what is going on, it's difficult to ship to, it takes a lot of time, and patients face a lot of challenges. They are bleeding, they are going to those centers. Sir, please come here. Very important, this is critical. That's how we are doing, you people, 10 people representing 10,000 patients at least, 10,000 live, their families. They come to us because our chapters, they play a key role. They come to, they are complaining to them, we are not getting it through a state. What we can do? We can only raise the voice. Sir, yes sir. So please divide you among yourself and tell about your state procurement practices so that we can...
companies of supply.
Despite budget, then there is a big constraint of inadequate supplies there. Yes sir, you also... Okay sir. Okay sir. Chem process, sir. Okay sir. Okay sir.
परफॉर्मेंस इम्प्रूवमेंट प्लान कि हमारे स्टेट क्या अच्छा नहीं हो रहा, और मुझे लगता है बहुत कुछ ऐसा है शुरू से लेके तक जो कि जिसको इम्प्रूव करने की, जिस परफॉर्मेंस को इम्प्रूव करने की ज़रूरत है। जैसे प्रोक्योरमेंट में इन्होंने सर ने बताया कि सबसे बड़ी प्रॉब्लम आ रही है कि एडिक्वेट बजट है, पर अब इस वक्त जो पर्टिकुलर प्रॉब्लम है कि कंपनीज के पास उतने मेडिसिन इतने फैक्टर्स ही नहीं है कि वो सप्लाई कर पाएँ। तो पहले हमें सबसे पहला हमारा पूरी एनर्जी लग जाती है, प्रोसेस है वो इतनी कम्बरसम है कि उसको मतलब कम से कम अगर आज हम एक एडमिन अप्रूवल लेके देते हैं तो उसको प्रोक्योर करने में कम से कम 4 to 6 मंथ्स तो लग ही जाते हैं, प्रोक्योर करने में कम से कम 4 to 6 मंथ्स तो लग ही जाते हैं, और तब तक
drug people are not able to afford, even you know middle class won't be able to afford that much. Let's not talk about the lower middle class and this BPL people. Another state, they also have budget approval as per the number of registered patients. They deny sometimes, like in Delhi and UP recently, this is what happened. They Delhi people, some they are living, some living in Delhi, NCR. I also live in NCR. So they go to Noida center, they go to AIMS center, they're denying, they're saying we don't have a state budget. So it's a very big problem, sir. What you are saying that 1 year budget was lapsed, so but patients were bleeding, they were having issues. वो कहीं नियर बाय स्टेट में गए होंगे, आपके आसपास राजस्थान अच्छा है जहाँ पे अच्छा बजट है, उनका सिस्टम अच्छा है भी. Ma'am, this will take forward. Yes. Very good, ma'am. We're happy to hear that because everybody knows ma'am is wife of ED NHSRC sir. And all EDL have been finalized in NHSRC.
I'm talking because I spent 30 years in the army and 10 years in the private sector now at Sir Gangaram Hospital, which is a trust hospital with lot of academics. In the armed forces, we used to have a central rate contract. With that, we could buy the stuff in Udhampur, in Delhi. Central rate contract. Need to get more companies into India. All over the world. The way is to tell them that the trials have happened, they are approved by the US FDA. Why cannot the DCGI or the CDSCO approve them?
Thank you very much, ma'am. That's a very good suggestion. I think everyone will accept it. I mean, everything has its pros and cons, but it's a very good suggestion, ma'am. Very welcoming suggestions. At least procurement delays and this administrative approval, what Gulati sir is saying, they're true. They're actually practically happening. We can at least take out that much. We'll be free that we have that much patience. This is our requisition. You procure and give us, so that we can do other quality work. You know, so data registry, monitoring, and all these things. So this discussion topic, yeah, we would also like to hear from sir, you. Yes, sir. Okay, sir. That's
problem is supply of equipment. प्रॉब्लम वही है सप्लाई की, जैसे रिलायंस के साथ हमारा टेंडर था, वहाँ से सप्लाई नहीं हो पा रही.
कितने पेशेंट्स हैं यहाँ पे हरियाणा?
टाइमली सप्लाई नहीं हो पा रही.
How many hemophilics are there as per government data in Haryana? आपकी टीम भी है सर यहाँ पे. पेशेंट्स हीमोफीलिया के कितने रजिस्टर्ड हैं? जैसे 5000 महाराष्ट्र में है, सर ने बताया 1800, सर 1800 तेलंगाना में है, पंजाब में सर 600. guidelines also.
झारखंड में हम लोग जो है हमारे यहाँ जो है और डिस्ट्रिक्ट लेवल पर सीएससी लेवल पर मेडिकल कॉलेज लेवल पर इन लोगों को भी अलग से फंड दिया जाता है और ये कॉलेज लेवल पर इन लोगों को भी अलग से फंड दिया जाता है और ये लोग जो है आयुष्मान भारत मुख्यमंत्री गंभीर उपचार योजना
से झारखंड में स्टेट गवर्नमेंट के सर रजिस्टर्ड विद आपके पास जो स्टेट के पास रजिस्टर्ड हैं हमारे चैप्टर भी वहाँ काफ़ी एक्टिव हैं और आप लोगों के साथ मिलकर उन्होंने काफ़ी अच्छा करा दिया है झारखंड में।
अभी
संतोष
इस पर
जी
ज़्यादा
हमेशा
फोकस हम लोग कर रहे हैं शुरू कर रहे हैं
यस सर
अवेयरनेस थोड़ा कम है
वो तो स्टेट प्रायोरिटीज नेशनल
तीनों को
प्रायोरिटीज समटाइम्स
इंटीग्रेट करते हैं
हुए हैं सर बट अभी और भी फोकस बहुत ध्यान दिलाना ज़रूरी है क्योंकि डिसेबिलिटी प्रिवेंशन जैसा सर ने कहा था कि वो होता है हीमोफीलिया में वो बहुत ज़रूरी है सर हमारी पूरी कम्युनिटी के लोग सर जिसको भी जैसे सपोर्ट मिले दे आर डूइंग वंडरफुल इन देयर लाइफ जिसको मिल गया है आजकल सपोर्ट कोई आईटी में इतना आगे है कोई आईआईटी में है कोई कहीं है गवर्नमेंट जॉब्स में है सभी लोग बहुत अच्छा कर रहे हैं डिसेबिलिटी प्रिवेंशन हमारे लिए बहुत इंपॉर्टेंट है
सिकल सेल जब हम सर्च करने जाते हैं स्क्रीन करने जाते हैं
center there are in our center there are in all district hospital there is hemophilia treatment center so factors are available in all district hospital but things is good now because under sickle cell elimination program there is registration of hemophilia thalassemia as well as sickle cell anemia so we have started registration of patient on that very portal also that will be easier to calculate our
yes sir we had entire
so
session
this is the
today
good
on that topic
everyone
but
should
yes.
enter the patient
That's true sir. Thank you very much sir so let's conclude this session because we have to move on with more presentations out of this session what we were able to see at least 3 challenges
Just an additional point, ma'am.
let me conclude sir first so 3 challenges which are common across all the states one is budget is one constraint second thing even if you have budget then procurement supply chain issues they are the biggest problem and then yes sir and yes, sir. Yeah please sir. You can actually you can raise tomorrow also we are here but let's move forward we will discuss formally informally on the stage of the stage and sir I would like to invite our let's facilitate the team Mr. Samar Singh sir is here sir हैं यहाँ? Our EC member from Himachal Pradesh. Sir is not there. Sir, then Balshiram sir, you can facilitate Dr. Sukhveer Singh sir, DGHS Haryana. So next is thank you sir, thank you very much. It's a pleasure to have you here, and we would like to invite Jimmy Manuel sir for facilitating Dr. Bobby Gulati from the state. Please welcome with big hands. Yeah, it's been only 3-4 hours. Everybody is tired. We'll like to ask Mr. Nehra to facilitate Dr. Amar Singh Naik. Thank you, sir. So next on the list is not there. We would like to, yeah, Samar Singh sir to felicitate Dr. Hitesh sir from the state government of Gujarat. Please come on the stage, sir. So, Mr. Santosh ji from our EC team next could felicitate Dr. N.K. Gupta from Government of Bihar. Please show some more energy. Yeah, you are here. I saw at the reception everybody is energetic. They were fighting for their rooms. So next, I would like to ask Vaibhav ji to felicitate Dr. Belua, Tamil Nadu. NHM team Tamil Nadu. Yeah. Good to hear your views. So next, we'll request our president to felicitate Dr. Nimai Mandal from West Bengal. So next, President sir, please, we request you to felicitate with Dr. S.N. Sahi also from Government of Jharkhand. So we will start with the next session. Your seats in the crowd. Wonderful, sir. Thank you very much. Yeah, so we are done with that. We'll now move on to next session. Oh yeah, Dr. Kendre, I'm sorry. I myself will felicitate Dr. Mahendra Kendre from Government of Maharashtra. Or we would like to request our EC member and Vice President Development, Ramu ji sir. Both from Sunilji. They are from both Maharashtra. Yeah, please come. Thank you, sir. Thank you, all state government nodal officers, to give us time for this event. It's wonderful to hear your views and very important because you are the one who are actually working at the ground and your voice is heard in government and state and center. Thank you, sir. I request Vaibhav ji to proceed with further sessions, our technical session. Next is Okay, Dr. Anupam Datta, sir. Thank you.
Thank you, Sarangaji, and all our distinguished state government officials for the informative panel discussion. Now, I would like to invite Dr. Anupam Datta. Dr. Datta is representing Roche Pharma, and he will enlighten us about the evidence towards adoption of policy change for better hemophilia care. Dr. Anupam Datta, please.
Good evening, everyone. So it was very nice to listen to various policymakers and the kind of nitty-gritties which are actually very important in the management. So we can talk about medications and drugs all day long, we can talk about clinical features all day long, but this is very important, and that's why probably we'll be talking a little bit on the policies. And what I will be representing here today is a newer, an overall idea, and then we will be talking a little bit about the newer medications and how they have kind of changed the treatment scenario and the outcome in most of the patients. So as we all know, hemophilia has a difficult childhood with the risk of intracranial bleed. You have the problems. In the adolescence, you have multiple problems coping up with the society, coping up with the peers. In the adulthood, there is a lot of challenges like with the bleeds as well as the other social issues. And again, we do talk about what will happen as the patient ages. Now, the whole concept of prophylaxis is you change the severe disease to a moderate or a milder disease. How do you do that? You give alternate day or once in 2 or 3 days the factor, and the factor level which is below 1% comes up a little bit above that, and you regularly keep on giving that, and that takes the patient from severe to a moderate. Why? Because many years ago, the Dutch Dr. Ida, she found out that the life expectancy in a hemophilia severe patient significantly different from that of the life expectancy of a mild or a moderate patient. So if you can just do that, you can obviously come up with a lot of improvement. But there is an issue with that. You do reduced the number of bleeds, but that did not guarantee that the joints will be extremely good, because the joints do ultimately end up damaged in such conditions. Now, obviously, there is joint damage because of the bleed, and when the blood is there in the joint, that itself is an irritant and causes further damage. Synovitis, ultimately joints get damaged, and it's kind of a cycle, and the inflammation goes on. Now, one more important thing, now there cannot be any medication, I do not know of any other medication in our medical field where we say 20 to 30% of it will not be useful, but it is still available. So if we say that pantoprazole, 20 to 30% of the people who take pantoprazole will have problem in gastritis, but so that will never, pantoprazole will be never be accepted. But in hemophilia, as we didn't have any other choice, we still used factors, whereas 20 to 30% of them did develop inhibitors. And once they develop inhibitors, you all know you have to be dependent on other agents like FIBA or Novo-7, which are quite costly. So yes, that was a problem. So, but again, you cannot actually predict who will develop, who will not develop. It's a little bit genetically predisposed. At the same time, it depends upon the high amount of factor if someone gets during a surgery or a major bleed, or probably there can be other high risks. Basically depends upon the mutation that it gives. And then there are challenges which I know everyone in this hall knows, that is absenteeism from the school, absenteeism from the work, not only for they made two simple changes. One is the treatment goal. The treatment goal earlier, it was that to prevent bleeding, just to prevent bleeding with the deficient factors. But now what they have said is prophylaxis is the standard of care, and this is what we should be hammering. Every one of us should be making this a point,
be there a patient or the policymaker, that prophylaxis is the standard of care for the people with hemophilia, and episodic clotting factor concentrate replacement should not be considered as a long-term goal, because that is the reason why we are having so much of disability in our society for this, because even if you give episodic, ultimately the joint is damaged. Second is, they've changed the definition of prophylaxis. Prophylaxis was the treatment of the intravenous uses of factor concentrates. What they have done is, prophylaxis is now regular administration of therapeutic products. Now, therapeutic products is not only the clotting factor concentrates, it can be the newer bispecific antibodies. You have newer molecules which are coming, and many of them are on pipeline. We have Mymed, we have emicizumab, we have concizumab, we have so many other factors which are there. Fitusuran is there, so many other newer products are coming. So all the products are there. So prophylaxis in hemophilia is regular administration of therapeutic products aimed at maintaining hemostasis. And as we were talking from the afternoon today, do not consider hemophilia as a disease, but just as a deficiency condition which has to be replaced. Now, this is the landscape. We all know we have so many, India has so many reported patients, 30,000 reported patients, but I am very much sure that there are many other patients who are undiagnosed and they are not getting the benefit that they should be getting. So here we have the bispecific monoclonal antibody that we have, emicizumab, which kind of binds the factor, activated factor 9 and factor 10, and this has a benefit, and they have claimed that there has been 1 to 3%, they get a zero bleed strategy. We'll talk about it when we talk about what are the benefits that they have said. So they have said that if in comparison to the on-demand therapy, there has been very significant reduction in the bleed rate, which is near about 1%, reduction in the joint damage, and improved adherence, because you have to take it once in a week, or in some cases once in a month or once in 2 weeks, and the quality of life improves. We will be talking about some of the real world data that we have from India. That is, indirect cost cutting is there, which I think Rahul's presentation in the morning, which in the afternoon we saw that there was significant reduction. 38 crore rupees was saved by the use of this molecule. So fewer hospitalization, less burden of the HTCs, and fewer surgeries and orthopedic complications and delays or prevention of inhibitor formation. And once you have the inhibitor is not there, so the bispecific, the other bypassing agents, their use actually reduces. The cost per quality of life, this was a study done by Tulika madam, and I think they have shown that there is a significant improvement, and the cost cutting in these patients, acceptability increases. The main cost driver was there, and as you can see here, this the balanced view shows that the subcutaneous bispecific antibodies, they had a prophylactic therapy that offers significant clinical benefit and quality of life. Now, this is the pooled data from the HEAVEN trial, which they did in the West. And in the HEAVEN trial, the HEAVEN 1 was on the adolescent children who had inhibitors. HEAVEN 2 was on pediatrics, sorry, HEAVEN 1 was adult with inhibitors, HEAVEN 2 was pediatric with inhibitors, HEAVEN 3 was those without inhibitors, and HEAVEN 4 was on with or without inhibitors, but they were adults, and there they used once in a week emicizumab. And this is the overall dosing schedule they had done, and this is what they were, this is the pooled data of all these patients, and the primary endpoint was the treated bleeds and other safety endpoints. Now, if you look at here, the treated bleeds were 1.4. That was significantly reduced. Treated spontaneous bleeds was 0.6, and treated joint bleeds was even 0.9. In the treated proportion of the patients with 1 or 1 to 3 bleeds, you can see 70 to 80% of them in various age groups came up with 0 bleeds. That's a significant change. 7 out of 10 patients or 8 out of 10 patients coming to you without any bleeding. Can you imagine that? They will kind of forget that they have hemophilia. This is what the overall mean annual bleeding rate over the period of time. And as you can see, now in the Heaven 4, you may see that the annual bleed rate is a little higher. The reason was they were getting once in a month. So when you take once in a month, obviously the chances of bleeding are a little bit more than you taking once in a week. But if you see here in Heaven 1 and 2, where they were taking mostly once in a week, significant reduction in the annual bleed rate. Look at this. This is where they looked at the target joint. So can you see the target joint? What do you say when do you say it is a target joint? A target joint is a joint which bleeds 3 or more than 3 times in 1 year, and reduction of the target joint is when you have 2 or less than 2 bleeds. 95% of the target joints were resolved. This was a significant results. Now this is the side effects, and you can see only 4 or 5 patients who had additional side effects for which their treatment had to be withdrawn. In them, thromboembolism events were seen in 5 cases. In 3 of the cases, actually thromboembolism event occurred because they were being used along with the APCCs, and that is the reason why probably they had a higher rate of bleeding, and they were all seen in Heaven 1 trial. So this was the conclusion. In the Heaven 1 to 4 trial, the conclusion was they improved the quality of life. The proportion of the patients were less than 3 bleeds approach almost 100%, low bleeding rate. Over 90% of the target joint became 0 spontaneous bleeds and traumatic bleeds, and it was very well tolerated. But this was a Western trial. So does this work for India? Does this actually happen in India? So what is the Indian data? Now this is one of the trials that I'm proud to say that I was a part of this. So this is a prospective non-interventional study to evaluate the impact of emicizumab in management of hemophilia in my center. So in this we had 40 patients. We took 40 patients. I will show this. So we had 40 patients where we selected that they had either inhibitors or they had severe hemophilia with multiple bleeds, and we recruited them over a period of 1 or 2 months, and we saw the baseline joint level bleed rate, quality of life, and FISH score, HGHS score, and gave them factor for 1 year. This is the interim result, which is only 6 months and which we have published here. The 1 year data is going to be published very soon, and you can find that. So this was the 40 patients. The mean age was somewhere around 15 years. They were mostly severe. 29 of them were severe, 70%, and some of them were moderate. 70% of them had inhibitors. Without inhibitors, and with inhibitors, we have 12 patients. 30% of them were on inhibitors. They had inhibitors. Most of them were actually on prophylaxis. They were on very low dose prophylaxis factors, and 2 of them were on on-demand. We had shifted all of them, and the total number of bleeding before this study started was 459 in all these patients, and our average number of bleeding in 1 year in all these patients, 11. That's a significant improvement. Target joint which was present before was 30, and no target joints were seen in 30. This was before. Now this is the joint score. Now what I did was, we can always see the average which is down there, which we can say that from 12, the joint score 12 plus minus 5, the joint score came to 4.8 plus minus 3. But I made a chart like this to show that each and every patient actually kind of improved patients. The blue dot is what they had the joint score before that, and the orange one is the mark after giving 6 months, and this is only 6 months data. All of them, the joint swelling, the joint redness, the joint movement, the angle of the movement of the joint improved in all the patients. And FISH is the functional assessment. So whether they can sit, whether they can run, whether they can eat, whether they can eat with a spoon. So you can see that the score actually improved from 27.5 plus minus 2 to 30.6 plus minus 1.3. But again, I have made for all the 40 patients, and you can see the blue line is what was before and the orange line was what was after. This is the number of 0 bleeds. So can you see here, before this was the amount of bleed. So annual bleeding rate, the average annual bleeding rate was 11, and that came down to 0.38. and you can see the target joint significantly reduced. Look at the zero bleeds. So 92.5% had zero bleeds. Then still some patients did have bleeds. 1 or 2 patients had hematorosis, 1 patient had hematuria. But see the reduction in the number of bleed. Why can't they live an absolutely normal life? And actually this is a very positive thing. This actually made us look at the quality of life. And this is again, we looked at the quality of life to see the EQ5D5L score in all the patients and the visual analog score. The EQ5D5L score increased from 0.79 to 0.96, and each patient quality of life increased, each patient. And again, in the visual analog score, it was again increased. So what we were trying to see here is the overall improvement, not only structurally, not only functionally, but also from the quality of life. So this was a significant, what we did conclude was based on our findings, there was significant improvement with emicizumab in our study in our 40 patients. Unfortunately, we have 150 patients, and we could not give emicizumab to all of them. So we do have patients who are on low dose prophylaxis, we have patients who are on extended half-life prophylaxis, and we also have a group of people who are on it's not changing, so it's some of them who are on demand. This is another study from India itself where emicizumab in children, they looked at 18 children from 1 month to 12 years. And you can see again, they have seen what is the annual bleed rate in this patient before and after. This is the amount of pre-bleed annualized bleed rate, 12.7, kind of similar to us, and this is what post-treatment there was 0.28, 97% reduction. And especially it is important in children, because in children the lesser number of bleed you have while they are growing up, you get more pristine joints later on in their life, and they will have more healthy and good joints. Target joints also reduced significantly. Here it was almost 100%. So they also conclude that then emicizumab was found to be really effective. This is another from Dr. Sheikh Bilal's center. Sheikh Bilal has done extremely well. Most of his patients are now playing cricket. I think one of his patients has now playing cricket in state level. So this was a retrospective study which was done to review the cases from June 2021 to 2024 of all the patients. Data was demographic and other data were collected. So this is the number of patients. So he had 73 number of patients. You can look here that even 2.7% of them were above the age of 40 years. And this is the age group. Most of them, the average group was, a median age was 14. 80% of them were on prophylaxis. Before that, 19% were on-demand therapy, and many of them had your target joints, and many of them had 2 target joints. And this was the prophylaxis level before that. And after, so this is the report. So before treatment and after treatment, the annual bleed rate has also reduced significantly, and also those with and without inhibitors also. This is another of his on-demand, where the ABR was before emicizumab was 11.5, and in the prophylaxis group it was 7.7, that reduced down to 0.04. This is the number of target joint bleed. 1 target joint bleed reduced, 2 target joints, and more than 3 target joints was seen in 7%. They all improved. So what I was trying to come here and talk about is that there's a change in the perspective. The change that we have multiple options now. Today we have emicizumab, tomorrow we may have newer other bispecific products, and all of these products have shown significant amount of reduction in the bleed rate and improvement in the quality of life. And the real world data is not only what the Western data shows, we are also seeing this in India. And I think there's a strong efficacy profile with these clinical trials, and this benefit is seen across the patient, across the various geographic regions from Kerala, from Kerala, so many people, the children are getting emicizumab from Jammu and Kashmir to Assam. And the real world safety data is consistent with the clinical trial and markedly reduction in the injection site reaction in the real world data. So cost is a factor, social cost is there, health system cost is there, out of the pocket cost is there. So if you look at the overall cost, probably the improvement in the quality of life and the number of joint bleed may actually justify the use of these medications. If we have cost constraints, where should we focus? I think we should focus on the pediatric patients. We should focus on the patients who have inhibitors. They should be the choice number one. Those patients who bleed very much, so high ABR population, and those with life-threatening bleeds like intracranial bleed or GI bleeds, and those living far away from a healthcare center. They should be the point of focus. So what are the key take-home messages? So it increases quality of life, it reduces the healthcare burden. The long-term cost saving is there, which we today saw in Dr. Rahul's presentation, and then there is increased productivity, which I do think today Madam was also saying that so many doctors are coming up with the hemophilia. In my medical college, we have 2 doctors, one in final year, one in second year, and they are doing very good in their studies, and they are on emicizumab, and I think they would make excellent doctors who would take up the cause of hemophilia in their future. Thank you all. Thank you very much.
Like to request our RCC North Shri Dharam Singh ji to felicitate Dr. Anupam Datta. Moving forward, our next session is about the industry perspective on hemophilia care. To moderate the session, I would like to call upon stage Shri Santosh Manivanan, our EC member and youth group representative.
Thank you, Vaibhav. Hello, everyone. So the next session that we have is the industry perspective on hemophilia care. We've heard from a lot of doctors, bureaucrats, and also healthcare professionals on how they treat hemophilia and how they use the products. Another important point of view should also come from the industry partners. So I would like to call upon stage our industry partners to share some perspectives on some questions we have. I would like to invite Dr. Monica from Roche. Dr. Monica from Roche. Mr. Sumit from Novo Nordisk. Ankit from Takeda. Dr. Hitesh from Pfizer. And Mr. Pratik from Alpha Drugs. Please join us on stage. Have everyone. Dr. Ankit Takeda is on stage. In the interest of time, I will go ahead and get started. So, first question I have is for everyone on stage, all our partners. So please introduce yourself and the products you have in the market and your vision towards hemophilia care.
represent a couple of companies in India. Now we have also factor 10. We have been in the industry for more than 2 decades. We have been supplying and doing our part.
Hi, my name is Ankit Mantri. I represent Takeda. Well, Takeda has a comprehensive portfolio for hemophilia for a very, very long time. We have plasma-derived factors, recombinant, short half-life products, EHL factors of both factor 8 and factor 9. We do have products for VWF, and our portfolio also has, inhibitor management through APCC. Quite significant presence in the country, and we are very proud that we have been witnessing this growth for patient care in hemophilia for such a long time. A lot to go.
Hello everyone, I am Dr. Monica. I represent here not just as the country access and policy officer for Roche Pharma. At the same time, I represent here as a doctor myself who has been in the medical field for more than 17 years now. And one amongst you, because my vision and the vision that our company stands for, especially in the case of hemophilia, is that there is a life beyond zero. The zero here means that there should actually be no bleed. So our vision is that any patient or a person living with hemophilia A should not bleed. And that is why we focus on looking at the innovation which is needed now. That is about prophylaxis. That is about standard of care, that is about emicizumab. And I represent a company that stands 129 years tall, known for its innovation, not just in hemophilia, in oncology, in ophthalmology, and in rare diseases as well.
Good evening, everyone. I am representing Novo Nordisk. Then we have standard half-life factor 8, that is Novo 8. Then we also have the range of extended half-life products like Asperoc and Refixia, which is also available in the market. We have a complete range of the products right now available in India, but we have some certain challenges related to the supply. That's why we are also request for all the institute and all the policymakers to have all the products in their formulary so that patient can be served in a better way with whatever the product is available in their formulary.
So the next question is a little more specific, and maybe the whole process of supply is probably the same amongst all the partners. So maybe one of you can answer this question. The second question is, how do you supply? What is the process that is carried out once you receive the order?
Well, interesting question. It's a very operational question, but let me try to explain it. So yes, there's a whole set of process which kicks off when companies receive the order. Since most of the procurement in hemophilia happens through public accounts, there is a validation of the order which happens. There are internal processes which ensure that the price at which the order has been procured is in line with the rate contracted price. There are redressing or labeling requirements from various states and institutions. You would have seen that all this procurement which happens to government accounts, there are relabeling for supplies in ESIC only, something of that sort, right? That calls for a very strict kind of compliance to labeling requirement. All that is done. We also look at the shelf life requirement, because again, all the states, different procurement organizations have different conditions. If the shelf life of the product is conforming to the requirement, it's fine. If it is not, usually a letter is sought to procurement organization and an exception is sought. It takes quite a while. Any approval in government process, however simple, it never is so quick, right? So all those processes are taken care of, and then after it's the usual shipment, in the standard cold chain maintenance, supply, the goods are supplied there, whether received, this accounted for, so on and so forth. So this is usually, I think, it's across standard practices which every company deploys.
Question I have, I would like all the partners to answer. So what are the challenges you face and how we as Hemophilia Federation can help you?
There are a lot of challenges. Let me process in India about procuring anything. Government tender based where product. Sometimes when we quote the product, do not have clear cut requirement could be erratic and it could be sudden. One of the very key things in human plasma products, that's what we are dealing in. We have to give lead time. Our principal companies, clear cut agreement or supply understanding, then it very good thing for the patients and as well as us. This is something which is more of an administrative thing. Besides that, of course, as particularly sometimes specific to one institution, we have particularly as a company faced that when we supply the product, whatever the agreed payment terms, they're never met to. Particularly our company, I don't know, I think other companies also in specific cases 4, 5, 6 times time, whatever we supply, what was agreed upon. So those are the issues we are facing, very, very practical issues.
Very important points. Other part of your question was, what can HFI do about it, right? That's a very interesting question. HFI done a great amount of work in terms of the kind of products which are required in the country, advocating for access to all the patient, ensuring that the treatment goes to last mile. Every patient in the country has a treatment that's in a very close proximity. All this has been phenomenal work. I think HFI can also shift the gear and get deeply involved into advocating for right set of procurement guidelines, right? It's been, if not years, but decades that our procurement guidelines have changed. What we are having, I use this word jokingly, is kind of, colonial era of kind of manual, which in today's context has lost its relevance. For a product, these kind of required medicines which can be life-changing on a given day, having those kind of terms and conditions are absolutely colossal, So that is something where HFI can take the matter to the appropriate authorities and really have a very deliberate conversation about that. Why do you require a shelf life of 80% for a drug which is life-saving? For a drug where you'll just chase the organization, please supply in 2 days. Why do you need 80% shelf life? It's a question, which every company asked. Secondly, the way to look at hemophilic factors or non-factor, any treatment, has to be deeply differentiated from, say, paracetamol. The quality conditions are very different. And it would be really good that states can have hemophilia-specific tender, which some of the states do. What that does is, adding on to his point, that there's far more predictability and stability in terms of conclusion of the tender. I will not name the state, but there have been examples where the tender process drags for 1 to 2 years. Imagine a situation where company has made a strong arrangement in anticipation of a tender outcome, and then tender is open, then it goes for retender, again 5-6 months limbo, then again retender. No one can plan for this kind of erratic situation. No one can. No company can, right? I think the time has come for HFI to step up, elevate this, advocacy level, and also bring in procurement-related, advocacy in this whole string of, work which is greatly doing.
I will not repeat what is said. I think the biggest concern I have, not challenge, concern I have is people within HFI also, and patients especially who are hemophilia A patients also, are they even aware of how valuable their own life is? I have an opportunity today that I can make someone's life better by giving a treatment that that patient is never going to bleed or almost zero bleed. Why will I not fight for it? It could be my family member, it could be my own brother, it could be anyone in my friend circle also, and it could be any one of you in the HFI also. क्या हमने खुद अपनी ज़िंदगी का महत्व समझा है ये जान के, especially when the country is talking about universal health coverage, saying leaving no one behind. And leaving no one behind के माध्यम से important ये है जानना, even hemophilia A, life matters. Do you have the power on your life today to make a choice that I don't want to bleed tomorrow? And if I don't want to bleed tomorrow, what am I doing to make this a cause that I can take forward and tell the government, tell the people who are making a decision on your life that I want this therapy which can save my life. I won't have joint bleeds. I won't have intracranial bleeds. I won't have intra-abdominal bleeds if only I can get best of the treatment. And what is the cost for that treatment that can save your life? It is not about the money. It is not about the value check that government needs to pay. It is about how much you value your own life. You want to fight for it, because that is where HFI can step up with the right awareness, right information, right scientific information, right product information, and then make a strong case that I value life of every hemophilia patient in my community, to make sure I make a case for it, I fight for it, and there are companies which are willing to support you at all levels if only you start to value your own life. And that is where my biggest concern is.
As procurement is concerned, so as I think we all are aware that India is a very complex country. I think as Ankit also highlighted that so if we try to follow those things, I think it will reduce a lot of pressure, because if we know that in that tender this is the quantity we have to import from the global, also take minimum 6 to 12 months time. So if we do proper planning, proper advance information to the companies, overall the supply situation will. I like to thank the procurement agency also. Sometimes they are also flexible. The request, they also have changed the timelines for some time. But it is not happening across India. So I think this is the time, I think, where we should differentiate the procurement of paracetamol to the factors or the other critical therapy areas.
Sure. Sure, the EC members and members of HFI are taking notes of all the valuable feedback. Next question is, What can the government change in their system to improve the delivery and quality of the drugs? In their system to improve the delivery and quality of the drugs?
There are two components on this, delivery and quality. Because it's very important to take recognition of the fact, do we have the right standards of measuring quality? Because most of the time when procurement happens, the only criteria that it has is which is lowest in price. How are we putting a price tag to quality? Because quality comes at a cost. And that cost is not what the money is. Cost is value to the patient, value to the society, and value to the innovator who's bringing that medicine. So the quality parameters have to be included, first of all, when it comes to procurement. Also for the reason we don't have a very robust health technology assessment system. Because if you look at the HTA systems where, countries like in Europe, in other parts of the world, where best of the treatments are available, they are only available because they are able to assess the quality through health technology assessment. And that is why, of course, government has made many strides. ICMR has set up the DHR department in which HTA mechanism is coming in, but we also have to get the best practices of the world to be part of it, so that that framework is participatory, what patients need, what government needs, and what as a provider, as a company that you can provide. And on delivery, I think it will be very important that there should never be a situation any patient of hemophilia should be deprived of the treatment just because the medicine was not available. Maybe because there was a delay in procurement, maybe because the funds were not released, and maybe because the supply chain was a challenge from a company's perspective. So very important is this forecast, and especially when this PIP plans are made, this forecast on supply chain is made, you get the one who has got the tender to sit with the government and say, I will commit to provide this much of medicine and this much time, provided you as government also assure that you will take care of this much volume. So it has to be a trusted relationship, and then only delivery and quality can be solved from a government standpoint.
I'll just give you a very small example here. All over India, there are tenders. Where it will cater to the one very brand. How the product should at least qualify on that basis. I know about a lot of places where normal. So I mean, what I'm saying is, there has to be a standard set. It has to be set at the highest level. All the bodies.
One addition to this conversation, we represent industry, but we also deeply recognize the dilemma the bureaucrats face every day, right? All of us, I think everyone here will agree that everybody's vision here is that no hemophilic patient should ever bleed. I think, that's common to us all. Are we there? Of course we are not there. It's a journey. Maybe someday we'll reach there. When we think of, bureaucrats, policymakers, payers, we understand that, there could be several situations. If you look at the spectrum where we are, where we could be, government will always think, do I do best for few? Do I do good for the most? Or do I do just enough for all? There is no easy answer to this question. however we may aspire for, but practically speaking, is a very tricky question to answer. And from that point of view, I am highlighting now, coming back to the question of delivery, government needs to find a very innovative way of procurement. Today, most of our tenders are all or none. You win or you lose. So you're there or you're just not there. Now that won't work. There are few states which has gone into, okay, if there is a L1 bidder, he gets launch share because that's how you get good pricing. But the bidder who are L2 and L3, they are given a chance to match the price and given same, say, 30-40% share. What does government achieve by doing so? They achieve good pricing, but also dependable 1 or 2, 3 source of procurement. It is very unlikely that all the 3 players will go out of the stock at the same time. So what you're ensuring is better patient access throughout the contract tenure. So these are some of the innovative ways through which delivery can be enhanced. And quality, I think both of my colleagues mentioned very rightly, there has to be a stringent technical criteria. Unfortunately, what we see today is a very long tender manual, and if you look at only technical piece of it, it is hardly 1 or 2 page, right? It has to be other way around. We have been highly fixated on the procurement terms and condition part of it rather than the technical quality aspect of it. That orientation, that mindset needs to shift for sure.
So the next question is probably going to answer the questions of thousands of people. Why are the companies facing issues in fulfilling state needs?
I can tell you from Roche, we are not facing any challenge. I think whichever state has put whatever request for emicizumab, at least that in the time that they had asked, and this is our commitment, not just for the states where we are today, but even for the states we eventually will go into, that we have a commitment for India. Of course, also knowing that the hemophilia burden is very high for India, I do not see a future where, at least from Roche perspective, it is ever going to be a challenge for the country. Thank you.
Face the challenge, but as a Novo Nordisk, we have faced. We have not faced only for hemophilia. We have faced all the therapies, whether it is diabetes, whether it is hormone therapy. We face for everything. Even we informed EMA, DCGI, and everyone last year regarding the shortage of our, which still continue. But I can assure you, and I can tell you that things are improving in the case of even for the Asperoc, because whatever the stock we were importing, now it is going up and things are improving. But it will take time. It is not going to overturn within a year of span, but things will be changed.
Let me dig a bit deeper into this problem. Though I have been hearing the panel before us, and there were problems, unfortunately, both in terms of supply from the company side and general supply situation. So, I mean, the plethora of problems exist, challenges exist. I broadly categorize them into 2 parts. One is just 2 factors, but there be a better forecast, better outlook. You know, those situations where a tender, you know, publishes with 1,000 requirements, just giving a number, but land up procuring 10,000, or ask for 10,000, lands up procuring only 1,000. Those kind of erratic, you know, outlook and the forecast brings lots of pressure to the organization. And most of these companies are multinational, no one manufactures in India. So there's a whole sort of process, you know, which is there for us to import well in time. And the patient is present wherever the patient is sitting, whichever country he's sitting. So when we, you know, get into those kind of conversation, it is never about patient of Thailand versus patient of India. Patient is a patient, right? So we all need to probably improve on our forecasting outlook, you know, those kind of management for us to avoid this situation.
The next question is, how does the industry look at the development of state-sponsored health insurance schemes?
This is a very important and pertinent question, because so far if I talk about hemophilia is part of blood disorders within National Health Mission. With the aspiration that the current government has, that they want to go into a universal healthcare, there has to be a sustainable pathway, that not every time patients have to depend on state government to support the PIP getting approved, marginal money coming in, supplementary money coming in, you know, shortage of supply. If there is an opportunity, and I'm more than happy to take it forward from industry perspective, if there is an opportunity that tomorrow government would want to consider a beneficiary package for hemophilia treatment, that will solve it for all. Like how Ayushman Bharat, if you have seen, with a 5 lakh cover, no matter what issue you have, if you require healthcare, you can go to, you have the ABPMJY card, you can walk into any government or a, you know, ABPMJY empaneled hospital and you get free of cost treatment. If similarly for hemophilia, government can look at state health schemes eventually rolling up to, you know, Ayushman Bharat PMJY scheme to have a health beneficiary package, then nobody needs to worry. If God forbid there's an emergency, a patient bleeds, he doesn't have to run about, you know, searching for where should I go get my treatment, but eventually he walks into a tertiary care hospital, he has the golden card, he walks in and he gets it. So my aspiration personally, and I think that industry would want to support anyways, is how do we look at, you know, a proper health beneficiary package for hemophilia to get included. And of course there are many state schemes. Most of those 90% of the state schemes are now rolling up to PMJY. That is why I'm saying PMJY. That maybe let's think of a beneficiary package for hemophilia. Why not?
Insurance schemes. Does your insurance schemes? Does your company or companies already have something in the pipeline? This new upcoming have a process in place.
Not sure if I get the question rightly. Let me just try to confirm my understanding. What you intend to ask is, do we have something in pipeline where we can partner with this kind of, you know, mechanism where access can be broadened through either universal healthcare, something like that? Okay. So I think overall, yeah. Okay. So I think overall, it's a great notion that in whichever way this scheme or that scheme, the access to be broadened. And whether XYG company has something in pipeline will depend upon the XYG company. But generally from the industry point of view, if industry can be engaged well in time, while you are conceiving these ideas, while you are conceptualizing this concept, it would be a great idea. There are very many concepts across the world. There are managed entry agreements, there are outcome-based pricing, there's whole sort of innovative models which are existing in the country, and there are use cases through which government and the industry can partner. We can really determine our costing, pricing, modus operandi, so on and so forth, which can make the, you know, the scheme run very smoothly. Today, do we have something? Again, Takeda doesn't have something of this sort. So, but yes, this kind of things can surely be worked out.
And proud the way we have looked at emicizumab and you know, therapy for hemophilia in India is to actually go state by state. Because I think we recognize very early that knowing also that health is a state subject. You can move mountains, but of course you need to start with steps, baby steps, and going strong. And saying that do we have anything in pipeline, I think we are already doing it. Why I say this also because opportunities, and I think more than myself, there are people sitting in the room from the HFI community, from the state nodal officers, recognize that we have gone very early to understand the state challenges. Will have funds. Maybe you don't even have a hemophilia treatment center. Sometimes a hemophilia treatment center is also there, fund is also there, but there is no technical know-how. How do you introduce a new innovation? What is the scientific rationale? So it's not just about state-sponsored scheme. I think a very pertinent point is to understand what is the access challenge. What are we trying to solve for? Is this money? Is this scientific knowledge? Or is this just a belief that you want to change your therapy or not? So I think the way forward definitely is of everything that we do at Roche, and that is why it is very pertinent that we look at those models. More than before looking into pricing models, it is important to understand the need of the state. Where is government struggling to understand the patient journey pathway? In that patient journey pathway, where we can come to support, whether on diagnosis, whether on treatment, whether it is about adherence to treatment. So that is how we look at things in Roche.
Thank you for all the answers. With that, I would like to thank all our partners on stage, even though you are all competitor. Questions from the audience.
लास्ट ईयर यही सेशन में मैंने एक फार्मा कंपनी को प्रश्न पूछा था कि आप फार्मा कंपनी अभी जो भारत में हीमोफिली के लिए जो फैक्टर 8 फैक्टर 9 की जो ज़रूरियात है उसके मुताबिक आप सप्लाई कर सकते हैं या नहीं। अभी इतना फैक्टर 8 और फैक्टर सप्लाई की वजह से हमारा PWH को इतना उसका पेरेंट्स को इतनी सारी मुश्किलें पड़ती है और जो हम हीमोफिलिया चैप्टर चलाते हैं हमें भी बहुत सारी परेशानी आती है। आप आने वाले समय में फैक्टर आप रेगुलर सप्लाई कर पाएंगे या नहीं कर पाएंगे, ये एक जवाब दीजिए। नहीं कर पाएंगे तो प्रेम हमें क्या करने का है, हमारी भी कुछ जिम्मेदारी आती है। फैक्टर के बिना हमारा पेशेंट को इसी तरह से हम परेशान नहीं कर सकते हैं। और ये लोग को एक ही प्रश्न है, ग्लोबली शॉर्टेज है, ये एक अच्छा शब्द फार्मा कंपनी को मिल गया है कि ये ग्लोबली शॉर्टेज है। फार्मा कंपनी कभी ग्लोबली शॉर्टेज हो नहीं सकता है। इसके बारे में आपका क्या व्यू है, जरा बताइए। ये बात का मैंने एक साल पहले बोला था, उसके पास आपके पास अभी कोई जवाब नहीं आया है।
Crunch for factor 9. We have got 17 patients in our center, and Novo Nordisk won the tender, and they have supplied me only 15,000 units of extended half-life factor 9. What to do? How can I treat 17 patients with this small amount of factor? I have floated tenders so many times. We are not getting from any companies. They are not coming up with a tender for factor 9. What to do? How to treat them?
I can reply only specifically to my company because with hemophilia A. In a tender, what we can supply and what we cannot. Our commitment has been always 100% before we enter into a contract.
नमस्कार। अभी जैसा कि हमारे दिनेश भाई ने कहा कि फैक्टर्स 9 के हैं, 8 के हैं, अदर्स फैक्टर्स की समस्या है। आप सोचिए, हम जो पेशेंट ऑर्गेनाइजेशन है या पेशेंट्स ग्रुप्स हैं, जब हमें ब्लीड्स होती है तो हमें सबसे पहले क्या चाहिए? मेडिसिन। अभी तो ऐसी स्थिति है कि हमारे पास बजट है। पहले हम सरकार को बोलते थे कि हमारे पास बजट नहीं है, हम कहाँ से खरीदेंगे। अभी तो हमारे पास बजट है। मैं प्रीवियस ईयर का आप एक डाटा बताना चाहता हूँ। सरकार ने जो पैसे सैंक्शन किए थे, भारत सरकार ने या राज्य सरकारों ने, वह इसलिए खर्च नहीं किया जा सका क्योंकि फार्मा कंपनी के द्वारा कमिटमेंट करने के बाद, अगर आप टेंडर निविदा में भाग लेते हैं, तो आपकी जिम्मेदारी होती है कि आप उस दवा की आपूर्ति करें। किसी कारणवश अगर आप नहीं आपूर्ति कर पाते हैं तो सरकार को आपको बोलना चाहिए कि हम इस कारण से आपूर्ति नहीं कर सकते हैं, आप दूसरी यह ऑप्शन आपको खुद दे। वह पैरासीटामोल नहीं है कि आप नहीं देंगे तो हम कहीं और से खरीद लेंगे, कोई और नहीं देगा तो हम तीसरे से खरीद लेंगे। एक लाइफ सेविंग ड्रग्स है। जिनके बच्चे दवा के अभाव में पैसा रहते अगर एक्सपायर करते हैं तो क्या बीतती है, आप कभी सोचा है? कभी नहीं सोचा है आप लोगों ने। आप सोचते हैं हम टेंडर्स जीतते हैं, हम दवाई की आपूर्ति करेंगे या नहीं करेंगे। कभी सोचिए, एक मानवपन के आप सोचिए कि अगर हम आपूर्ति नहीं कर पाते हैं तो हमें स्पष्ट सरकार को सच्चाई बतानी चाहिए कि हम इतना पार्ट ये करेंगे, आपूर्ति करेंगे, इतना पार्ट अदर्स कंपनी से भी लिया जा सकता है ताकि दवा की कमी न हो, लेकिन दवा सबके द्वारा दूसरे कंपनी से, तीसरे कंपनी से खरीदा जा सके। यह आप लोग को करना चाहिए।
Okay. In the interest of time, I would first of all like to thank the members of the audience for the points that they have brought up and the important questions. All of our partners have stalls outside of the area as well. We have other topics to cover as well as other sessions. So I would please request everyone to take questions offline. Okay, ma'am, please go ahead.
I think everybody's okay, because one kind of question we understood as they have already explained. Short, and we understood the crux already. All good. But the thing is that if the tender is not going through, the government is making up the things that if factors can be purchased locally also at the district levels by the things, and when they are placing the locally orders also, because tender is not getting through, that the government process is there. But then we are making the things that please for the patients give us locally, and the companies are not providing those factors locally for the patients because they tell us they have a commitment. When the tender gets through, they have to give that much of commitment of the amount for those for supply to the state, so they are not making it locally procurement also possible. That is a very sad state. So how you can tackle it? Because if our states and our district officers from the government hospitals are giving the local tenders also for small amounts, so that the patients do not suffer. See, the government is taking up three-pronged strategy for this. They are taking up at the central level from NHM, they are taking up at the state level also for the whole state centralized, and as well as the local level for that small number of patients which are locally there in those chapters. But still the pharma companies are not making up for that. That has to be catered.
One of the very good suggestion you have given is tender L1, 2, 3, so that there will be never ऐसा नहीं हो सकता कि सारी कंपनी का सब जगह से माल खत्म हो जाए। वन वेरी गुड सजेशन। दूसरी चीज़ एक रिक्वेस्ट करूँगा, जो हम लोगों को भी प्रॉब्लम कई बार आया, शार्ट हाफ सेल्फ लाइफ का प्रोडक्ट है, आप एक अंडरटेकिंग दे दिए, हमें मालूम है, ब्यूरोक्रेट्स को नहीं मालूम है। क्यों? क्योंकि वो 6 महीने आप 2 साल का टेंडर में भरवा रहे हो, 1.5 साल का मिल रहा है और 2 महीने में एक्सपायरी आ रही है, वो तो 2 महीने में 3 महीने में यूज हो जाता है। तो एक आप अंडरटेकिंग दे दीजिए कंपनी की तरफ से, इफ़ नॉट यूज वी विल टेक बैक एंड गेट वन। दूसरा एक सब लोग IRCTC एंड ये रेलवे का यूज करते ही हैं, देयर इज सम ऑटो अपग्रेडेशन। एक सेकेंड क्लास second AC ticket, if some seats are vacant and you have taken option, that automatically upgradation, so 2 or more seats will be given to like that. For the time being, you can bear this cost. Certain percentage you can decide. Ultimately, everybody's aim is nobody should bleed.
हेलो तो जो आपने बात बोली not flexible in India. Hello. As far as patients limited means, we are been doing that.
वॉश के बिहाफ पे बोलूँ अगर तो हम फैक्टर्स में डील नहीं करते हैं। इसीजुमाब नॉन फैक्टर थेरेपी है। कोई भी अगर कंपनी कोई नया प्रोडक्ट लेके आती है मुनाफा भी कमाएगी, कोई ना कोई कारण ही होता है। मैं आपकी बात समझती हूँ जहाँ पे ये बात आई कि कितना समय लगता है और आपको अंदाज़ा भी नहीं होता कि उस टाइम पे कि कंपनी के पाइपलाइन में क्या चल रहा है। इम्पोर्टेंट यहाँ पे ये है कि ये समझना कि क्या इंडस्ट्री कमिटेड है कि नहीं है। अगर मैं रॉश के बिहाफ पे बोलूँ, आपने फैक्टर्स की बात की, नॉन फैक्टर भी थेरेपी है। अगर आप लोकल परचेज कर सकते हो तो आप गवर्नमेंट को ये भी बोल सकते हो कि दूसरी दवाई अवेलेबल कराओ। ये आपका हक है मांगने का और ये आपको मांगना चाहिए। बट मैं फैक्टर के बिहाफ पे फिर भी इसलिए नहीं बोल रही बिकॉज वी डोंट मेक फैक्टर्स। डायलॉग भी कर रहे हैं गवर्नमेंट के साथ, क्योंकि जब टेंडर होता है तो गवर्नमेंट करती है, परेशानी होती है तो फिर HFI के ऊपर आता है कि मरीजों का फ़ायदा नहीं हो रहा। ये बात है कि ज़रूरी है कि कंपनी है, जो गवर्नमेंट है और जो पेशेंट ग्रुप है, हम सबको साथ में मिलके काम करना है। हमें एक दूसरे से लड़के काम नहीं करना है, एक दूसरे की मदद करनी है कि हम प्रोसेसेस कैसे ठीक करें, रादर देन हम ये क्वेश्चन करें कि ये दवाई नहीं थी, आपने क्या किया। Work together as one team, not as two different teams. Why not let's just move ahead and make it happen. Thank you.
Thank you for the answer.
There are very patients such as ma'am, as you highlighted, the tender is in limbo, tender is not getting concluded because of whatever reason. For local purchase, and of course companies may find it very difficult to even provide for. I will say there are some very good practices by some of the states, right? There are states, I can name it UP, excellent practice. They do make sure that before placing the order, they will get a confirmation from us. They will let us know, okay, this is how the situation is looking like. This is our quarterly demand. Do you have this much? Say, okay, we have this much, no worries, please place the order, we'll supply. If at all. Well, there's a situation where we believe that, okay, maybe we are not in the position to supply, which rarely happens, that we are not in the position to supply, we tell them very happily, okay, if your requirement was 100, I can only fulfill 80, please place 20 order to someone else. Absolutely fine. Santosh ji said a very important point. See, L1, L2, L3, everything is process. What is most important, what is real, is a patient who is bleeding. That is the most important of all. Now, no company, for that matter, let me also articulate this from industry point of view. No company wants to land in that situation. Why do we produce factors on any medicine? Not because we want to keep them into our warehouse. That's not the purpose. What do industry achieve by keeping the products in the warehouse? There's no purpose which is achieved. Drug only work where they're inside the patient vein in the blood, right? If that all that is happening, we all need to collectively understand where are the potential bottlenecks, how can we ease and improve the situation. That's where we are. You know, it's a multi-stakeholder process. Simply saying that why don't you do it, it's also good, we understand that, but I think this required multiple checkpoints, multiple interventions across a level where the overall process become more effective. So I'm looking at this area for last 11 years very closely, and probably in last 1 year or so we are having this kind of situation. Other than that, all these 9-10 years the situation is different. You know, there's no money, there is less money, there are more factors available, more requirement, money is lesser. And one thing which you all need to learn from this, again, because we all need to be pragmatic and future looking, because problem keeps evolving, right? Today, because few companies may have some temporary blip in the situation, we should not let go of the higher purpose. Higher purpose is elevation of standards of care, access to all, better treatment center, good guidelines. If we keep, this is very important, extremely important, that we must pay focus to this, attention to this, but not lose sight of the larger, bigger purpose, because this will probably ease in the next 6 months, 9 months, and we'll come back to the previous situation. So let's also look at short-term problem and also long-term objective which we want to achieve. Having community together.
All good answers. Thank you very much.
Support of the patients. When Redexa came, they said we'll give idurusumab free of cost if someone has side effect. What have you done as a company to provide if the baby requires a emergency surgery? Normal, factor 8 Bethesda is not going to pick up, and he has to be shifted to factor 8. Imsuvizumab will not work. What have you done to provide for the chromogenic factor 8 SA and Bethesda for the patients that you are giving expensive drug? What has your corporate social responsibility been getting this drug into India?
I'm coming to your question. There are guidelines about usage of emicizumab, indications for usage of emicizumab, and there are also off-label use doctors are doing on their own that Roche does not acknowledge. Let me finish this. And that is where my challenge is. If we are following the indications and the proper dosage of emicizumab, the patient on emicizumab will definitely bleed if there is an accident, but the bleed is going to be as normal. I'm coming to that. Bleeding is going to be as normal as any other patient who's a normal person. Now you're talking about an emergency situation. If in an emergency situation there is a bleed and patient requires factor 8, I assume if it is I don't know what the prevalence will be. No, I'm saying the prevalence. I'm assuming the prevalence. Because this is for the first time someone is coming and asking that what Roche should do on this. My question is, what are we doing as physicians to ensure that factor 8 and everything is available in the emergency? Because I will not know sitting in my office when a patient is going to bleed. And as a policy of CSR, we do not do drug donations. We do not do medical support. Agree. I meant doctor only.
As a first DOAC for atrial fibrillation stroke prevention, they knew that occasional patient can bleed. They said we will give idarucimab free of cost. Okay, now if you know the basics of coagulation, because you've not done anything on factors and you've come. So in the world, they came up with imosuzumab. They also established, your own company, established the center where this patient could go in for a chromogenic factor 8 assay, which routinely is not done because it's a clotting based factor 8 assay all over the country and APTT. So they established it everywhere where they did the work, except for in India. Because in India no one asks this question. So they should be, if you are saying kuch nahi mil raha, I will give imosuzumab, that's what you said. And when you said kuch nahi mil raha, I will give imosuzumab, what backup do you have for a child who has an accident, who requires an emergency surgery? Why I'm telling you, as a hematologist sitting in Delhi, patients from Calcutta who have got it, or from other places, I'm not going to take the name, are getting imosuzumab and now require a surgery. They are running from pillar to post because APTT is normal, Bethesda assay is normal, factor 8 assay by clotting is normal. So after the see, it's not a cost-effective test, so labs will not start it because 20 people are imosuzumab, or 50 or 360 in Gujarat. So Gujarat has put 360 through NHM on imosuzumab. Have you set up a center with chromogenic factor 8 assay over there and Bethesda assay there? That is your responsibility.
Can I finish, ma'am? You made a very pertinent point. You talked about countries which have invested heavily in upgrading their healthcare system. You're talking about countries where they have reimbursement in place to say that all patients only get this particular drug, and we have invested to make possible that even if there's an emergency, we have a provision for that. I will do it for India, you take my commitment. If tomorrow the government, no, definitely. If tomorrow government
Dr.
comes,
Shah clearly said that Gujarat has 360 patients of
Let
imosuzumab.
Gujarat come and ask
In
us.
Gujarat, that should be. Have you gone and told them that these will be the problems? Have you told them that when this child requires an emergency surgery, your factor 8 assay will not work, your Bethesda assay will not work, your APTT will not work? How are you going to monitor and give? And during surgery, factor 8 has to be given. Imosuzumab cannot be. The knowledge related to the drug, has it been given to the doctors using it? No. I've talked to a lot of physicians. That's why I said I'm a hematologist, I'm not a physician. And then the patient is running from pillar to post. Kis lab mein hota hai, mere ko bata do. So you should have, when you are selling this drug in India, at least one central lab. When there is an emergency of your patients getting prophylactic, you should have the facility to provide that emergency chromogenic assay to your patients. And that should be your corporate social responsibility.
No, I agree to everything that you said. I agree. My only concern is we need to upgrade healthcare systems to come to that level.
That
to
will
make it
take
happen.
time. They are not even doing factor 8.
You can have 10,000 wish list for us, but we also have to be cognizant.
You are upgrading to the drug which is the best.
We also have to be cognizant that if tomorrow India comes to that critical mass, that even 20% of hemophilia patients are on emicizumab, I will make it happen.
No, you have to make it happen now. Then only 20% will find it safe enough to shift. You know, when they came with Predexa, if you are a doctor, you can understand what is Predexa, dabigatran, direct thrombin inhibitor. When they came with Predexa to India for stroke prevention and atrial fibrillation, first DOAC to come into India, they came with 1 in 200 patients, 1 in 1,000 will require. If there is a bleed, the very expensive antidote, idarucimab, will be given free of cost by the company.
Why don't we do one thing?
So
take
you
your point.
have to take this, you have to spread the education.
Let's just sit down. Let's also, because as of today, emicizumab is only supplied through government system. Let's just sit with the government. Let's have the right treatment guidelines, and we will make sure that this should become part of the guidelines also. Because madam, you need to understand it's only in the government healthcare system right now. acknowledging it.
Monica,
take your
thank you.
feedback.
Okay, I think it's a very, very, very good debate. In fact, the first time I requested industry was last year. The idea was that we definitely know we have been 2005. There's only one we try to understand the pressure which this room is going through. Many factors have played a role. We are all here because of everybody in the room, the kind of dedication which the doctors have given, the kind of a support which the governments have given is making us very confident today. The best way and the only way to work is when there is a proper collaboration with the government. These four partners are together. Thank you so much. The debate was very good. Thank you so much.
I would like to thank all the partners on stage, and as Prem sir has already said, I hope you take the constructive feedback as points to work on, because as you know, all the points that were discussed come from a point of sheer passion for hemophilia and just plain survival. So again, I would like to thank all the partners. You are competitors off stage, but you shared a stage here today. That shows your commitment to hemophilia. So
Hello?
So,
yeah, I am Dr. Suneet Singh Ranawar, working as Director, RCH, Government of Rajasthan. You rightly said so. Long purchase, big purchase, and I have been as an administrator at SMS Hospital for 20 years. Roche especially. I have no grudges against anybody. There are two, three things which I was observing as an administrator. One thing, you said you don't share social responsibilities. No, well, I'm not, I'm a listener. You know, I'm an administrator. I'm telling you very frankly what I heard. Publicly, all of us. You said you don't get social responsibility. Let me complete. Let me complete it, ma'am. You said so. Number two, you said if the patients buy 20% of them, then I will do these things, which is not there. If you sell a product in a country, it's your responsibility. When we want our children not to bleed, it is your responsibility to sell a product and ensure nobody bleeds. Number two. Number three, I find it very arrogant in a way. We are all users. We are doctors. If I float an idea in my state, I'm telling you very frankly, this is the Roche verdict on a stage. It would be difficult. And I know who all are using, because I have been working at a state level. For heaven's sake, we are all here. We are here to build a relation. We are here to serve the community. We are really, really for downtrodden, because I am a son of a Fauji officer. So I just talk in terms of humanity all the time. For all of us, be empathetic, share some social responsibilities. Roche is a very, very nice, and your products are anyway very high. That is why few other companies are coming with this Roche product in India. Thank you so much. I don't want to make it a more debate. And if you say so, we can discuss outside, because if you say, I have to stand again, and we have a long debate all throughout night.
No,
So
only
please, thank you so much.
Thank you very much, sir. Thank you very much, sir, for your feedback, which I take.
in the interest of time, I would please request Dr. Monica and Dr. Sir to take the conversation off to the offline. And thank you for all the comments. So up next, thank you all the partners for being here.
Thank you very much.
Thanks a lot. Up next, we have a very interesting session on diagnosis by Dr. Bipin Kulkarni.
Moving forward, I would now like to invite Dr. Bipin Kulkarni from ICMR, National Institute of Immunohematology. Dr. Kulkarni will be enlightening us about the point of care kits in hemophilia and genetic diagnosis, prevention of hemophilia. Dr. Kulkarni, please.
Very difficult to speak in the very last session of the day, but still I see sizable audience here. So thank you for being here. So just now had a very interesting debate.
I request everyone to kindly settle down. Kindly settle down, everyone.
Please, whoever wants to have some discussion, please discuss outside. Dr. Bipin sir has come all the way from Mumbai to discuss and share his knowledge with all of us. So please, everyone, be seated. And if you have any discussions, please do it outside the hall. I humbly request you all, please allow Dr. Bipin sir to continue his sharing of knowledge. Thank you.
First of all, thank you very much, Hemophilia Federation of India, for inviting me here to speak on this topic. So this was the original topic given to me. I have not changed the original title, but as Mr. Prem said, I'll be talking a little bit about the point of care test which our institute has developed, along with some genetic aspects and prevention of hemophilia. Since this is a mixed audience, I have not made this presentation very technically intensive, so as to address everyone. So I'll just touch upon some inheritance, like the basics of hemophilia and something about von Willebrand disease, because it is very much related with hemophilia A. Then I'll talk about the point of care test kits which was developed by our institute, particularly Dr. Srimati Shetty and her postdoc student. Then we'll talk about the prevention strategies, then the testing of hemophilia, particularly the genetic testing, who, when and how, and then I'll go on to the frequently asked questions on genetic testing, and then the way ahead challenges and the future directions, the conclusion. So we all know this, the pattern of inheritance of hemophilia. It is X-linked recessive disorder. So these are the various combinations one can have genetically. The most common one is right in the middle. The mother is a carrier, the father is unaffected, and that is the progeny. So you have 25% chance of having a hemophilia male in every pregnancy. So when we talk of hemophilia A in particular, we also need to understand von Willebrand disease, because many a times we see that a patient, particularly from far off centers where von Willebrand testing is not done, the patient is diagnosed factor VIII deficiency and labeled as hemophilia A, but in most situations the von Willebrand antigen is not tested. So there it becomes difficult when they come for a carrier diagnosis later on, or a prenatal diagnosis, because the diagnosis of the proband in this case is not confirmed by doing hemophilia A. Diagnosis is not confirmed by also doing von Willebrand antigen at least. So hemophilia, as we know, is X chromosome linked, whereas the von Willebrand disease is autosomal. So The inheritance is different, though the bleeding manifestations may overlap to some extent. So one has to understand why von Willebrand testing is important, because if you come for the genetic testing or the carrier diagnosis, and if the patient is von Willebrand disease and not hemophilia A, the complete gene will be different, and we are looking in the wrong area if he is labeled as hemophilia A. This has happened actually. So now slowly I'm coming towards the point of care testing. So why it was important to take up this? So this is slightly older slide. So registered hemophilia A patients, now it has improved a little bit more, but these are the figures actually. So this is the number of patients, expected number of patients of hemophilia in the country, and the estimated VWD population it is registered was around 800 at that point of time. So it was very essential to differentiate between hemophilia A and von Willebrand disease. There are still not too many centers doing the differential diagnosis and leading to confusions. So there was treatment is available in India, and the HTCs are also there, but only a few centers who do the diagnosis of factor VIII, and only 5 centers which are doing von Willebrand antigen testing. So there was a need for bringing up a kit which can at least diagnose the severe or the moderate cases of hemophilia and von Willebrand disease. So with this in mind, Dr. Srimati from our institute, along with her postdoc student, they came up with this concept of developing a rapid card test for von Willebrand and hemophilia A. So this kit can detect, the cutoff is 5%, so anything below 5% can be picked up in these kits. And these kits are out in the market now, and they are being manufactured by Bhatt Biotech Bengaluru. It's a Bengaluru-based company. So these are the strengths of the kit. So it requires very small sample volume. The cost is low, 200 to 250 rupees for both these kits. Reproducibility is good. There is no requirement for any technical or trained person, specialized training, as you otherwise would do if you are doing conventional von Willebrand testing or factor VIII testing. There is no requirement for expensive equipment other than a centrifuge, which every lab has, and it gives the diagnosis in about 5 to 10 minutes. So how this POC is going to change the diagnosis and management scenario? So this can be a first-line diagnostic investigation for any patient presenting with bleeding disorders. So it can be used in emergency or casualty departments, in the hospitals, obstetrics, ob-gynae, hemophilia chapters and hemophilia treatment centers. And the early diagnosis will definitely ensure initiation of appropriate treatment for these patients and prevent the morbidity and mortality. So this was launched by the then Honorable Health Minister here in Delhi. So now these kits are now available. So now we'll come to this was about the POC kits. So now we come to the prevention strategies for hemophilia. How do we do it? So the first and the foremost is proper counseling of the patient. So counseling meaning provide information to the families about the inheritance patterns of hemophilia, so that they can do informed decision making regarding the family planning and carrier testing. So next comes carrier screening. So once a patient of hemophilia is identified, it is important to identify the possible female carriers, and it will come through the counseling and a two-way dialogue where you identify who could be possible carriers and then do the carrier testing. Then comes the prenatal diagnosis. Once you identify the carriers and once the carriers get pregnant, then you have to counsel them for prenatal diagnosis. The ideal time is in the first trimester. So these are the different mutations or the genetic variants, pathogenic variants that we see in hemophilia A and hemophilia B. In severe hemophilia A, the most common one, about half of the patients have the intron 22 inversions followed by intron 1. And in hemophilia B, these are mostly small mutations, what we call as point mutations. The more challenging is the hemophilia A, because the gene of factor VIII is very, very big. It is 186 kilobases with complex mutations in some of the cases. And overall in hemophilia, there are 30% de novo cases, that is new patients every, so that the rate is 30%, it's very high. So it is important to understand who is an obligate carrier of hemophilia. So, so basically what is a carrier is a female who has factor 8 or factor 9 genetic pathogenic variant. So that lady is called a carrier. So who is an obligate carrier? So a biological mother of a child with hemophilia who has at least one other family member with hemophilia. It could be her brother or any other male member, that is maternal grandfather, uncle, nephew, or a male cousin, or who is a known carrier of hemophilia, who is related to her. It could be her mother, sister, or maternal grandmother, aunt, or niece, or a female cousin. Biological daughter of a father with hemophilia, so she is an obligate carrier, and biological mother of at least 2 or more sons with hemophilia. So these are obligate carriers. So who is a potential carrier of hemophilia? You know, could be a carrier, may be a carrier, may not be a carrier. So a biological daughter, sister, mother, maternal grandmother, aunt, niece, or female cousin of a carrier of hemophilia, or a biological mother of a child with hemophilia and no known family history of hemophilia. So it could be a de novo case. So she may or may not be a carrier if there are no other family members affected. So when should a carrier test be done? Ideally prior to marriage or prior to at least conception. Because in many cases we'll end up patients already pregnant, cross 12 weeks, and now they have come for carrier testing. So they should have done the carrier testing much before. So another question is, do carriers have risk of bleeding? Yes. So about 30% of carriers have at least have less than 40 to 50% of factor levels. So these patients can bleed. The factor levels range, they widely vary from 16% to 150. If you take the range, it also, the factor level also varies according to the blood group. As we know now, O blood group individuals carry, the factor levels are on a lesser side as compared to the AB. And another reason for a female to bleed, a carrier to bleed, is a phenomenon called extreme lionization of the X chromosome, which because of which the lady can bleed. So whom to offer genetic testing? That is the molecular testing. So a person who is clinically suspected of having hemophilia or with a confirmed laboratory diagnosis of hemophilia. So his blood level is tested, the factor level is low, and then he becomes eligible for a genetic testing. Obligate carriers to identify the molecular variant, because if the father of a girl is hemophilic, she is an obligate carrier, but still you need to do the genetic testing to find out what the mutation is, because tomorrow if she gets pregnant, you need to know what the mutation is. Or at-risk female family members to establish the carrier status. Now, symptomatic females who can have low factor 8 or 9 level, but even though there is no family member having hemophilia, so if a lady is symptomatic and the factor 8 or 9 is low, genetic testing should be done to predict the risk of inhibitors in many, if you have the null mutations, then you have a higher risk of inhibitor development, that is, so you can do the genetic testing there. It was also done to predict the response to ITI treatment. In many cases it is advised. Though the genetic testing is mentioned in all these cases, practically as a tertiary referral center also, we get so much load of carrier and prenatal itself that we cannot do the genetic testing of every diagnosed hemophilia. It is practically very difficult to do. But ideally it should be done if you can do it. So who are the essential family members required for genetic diagnosis of hemophilia? You need the index case, hemophilia affected family member. Of course, it could be your brother, maternal uncle, father or son, and the parents if you are doing a carrier testing. But in any which case, the index case is very important here. So these are the gestation periods if you want to do prenatal diagnosis. The best time is to do it in the first trimester, where it is easier, it is less risky, and you get a good quality of the CVS tissue, which is important particularly for the inversion mutations. Because if you wait till the amniocentesis, the question of cell viability and how much DNA and the yield, all these questions come into this thing, and the whole exercise could be futile, because many times what happens is the patient is not in town, the patient is somewhere else, and then it is asked that can we do the amniocentesis and send the cells, because that is very, very risky, because the cell viability is a big question. We don't encourage sending the amniocentesis samples to us. CVS can be sent because it is quite stable, but not the amniocentesis samples. So this was the earlier method that we used to adopt, that is by using the RFLP and the polymorphic markers. But now what is advised and what we do is the direct DNA testing. We don't rely on these markers because they have some inherent limitations of using the polymorphic markers. So here the presence of index case and other family members, you need the whole family for doing the linkage analysis. Non-paternity could pose a problem there, and then later on to counsel the family is another challenge if you face non-paternity there. There is ethnic variations, so your markers may not be informative in many situations. So when another question is when extragenic markers are used, there is always a risk of misdiagnosis because of recombination events. So it is not a 100% foolproof method, so risk is higher. So the direct mutation testing is what is advised, and that is what we also do. So this is just the workflow of how we go by it. So we do it by what is called DNA extraction, then PCR and sequencing, but before that we rule out the inversions, intron 22 and intron 1 in case of hemophilia A. So the prenatal diagnosis reports, then how the reporting is done. So reporting is either affected or unaffected. So if the report is affected, it is obviously a hemophilic male, and if the report is unaffected, it could mean that it could be an unaffected male or a non-carrier or a carrier female. In both these situations, the report is unaffected. So I am not sure whether you can see this, but these are some of our reports that I have put for antenatal and carrier diagnosis. So the reporting time, now ideally it is 10 to 12 working days, but it could vary in some situations because of the technicalities. If the patient has some unusual mutations that we sometimes encounter, or there are any genetic mosaicisms or any other technical problem, then the reporting time may vary, but on an average it is about 10 to 12 working days that we take. Can the patient family know the sex of the fetus? No. As per the PCPNDT rules, we are not allowed to reveal the sex of the child. There will be only two kinds of reports, as I said, it is affected or unaffected. So the carrier report is not issued if it's a girl fetus. So it's only an unaffected report that is given. So can samples be sent by courier? So as I earlier said, for genetic testing the samples can be sent by courier, but in these samples we cannot do the factor levels. So the problem here is, if the proband or the index case in the family, particularly in case of hemophilia A, if the proband is well diagnosed, factor 8 is done, von Willebrand is done in a very reliable lab, then we can rely on that report, and then we can say that okay, you can send the EDTA samples and we'll do the genetic diagnosis. But if only factor 8 is done and the patient is labeled as hemophilia A, we tell that if you are from Delhi or some good place, we tell them you please go to your nearest center like AIMS or any other center where you can do the von Willebrand antigen, get it tested, you send the reports, let us confirm that, then you can send the family members. Otherwise, if possible, you come, let us diagnose the index case ourselves and then we'll do it. So that is to avoid any further complications in the diagnosis. But of course, if the samples are sent, then the responsibility of keeping accurate identity lies with the family or the person who is sending the samples. So are there any risks associated with sampling procedures? So as per literature, there is a small risk of abortion due to the sampling itself, but the risk increases as the gestation increases. But in our experience, we have not encountered, touch wood, we have not encountered any procedure related miscarriages so far. So we were lucky to have very good sonologists who did good sampling for us without any encountering any such problems. Can a carrier antenatal diagnosis report be kept confidential? Absolutely yes. The carrier prenatal diagnosis reports are issued only to the family member or the authorized person to obtain the report, and it is not given to anybody else or revealed to anybody else. Are there any misdiagnoses by DNA analysis? So, see, no technique is 100% foolproof. There could be some misdiagnosis. Even in the genetic diagnosis, the risk is reported as between 1 to 3%. We have had one misdiagnosis when it was a RFLP based method, because as I said, the recombination events, you cannot be 100% sure by that. So how to offer genetic diagnosis when the index case is absent? So in some cases this happens. So what we have to do is, first you rule out the inversions which are most common in severe cases in the carrier females, and after that, if the inversions are negative, then you do the direct DNA sequencing of factor 8 or factor 9, whichever is the case, to identify if there are any potential disease or the pathogenic variants that we identify. So for deletions, there is another method called multiplex ligation probe based amplification, that is MLPA, that we use to identify if there are any possible deletions. If you don't get anything, then it could be a deletion that we go and look into. So in the absence of index case, the mutation analysis have to be done by in silico. So if we find a variant that could be pathogenic, so we have to do in silico analysis and see if use bioinformatic tools to see if this variant is actually high on prediction of being disease causing variant. So these are some of the tools that we use. There are many more that we use nowadays for predicting the pathogenicity of the variant. So this data is evolving. We have now this is not a very updated data of our cases of carrier and prenatal diagnosis in various conditions. And the way ahead, as we know, we'll be listening to Alok sir tomorrow. This is a very promising gene therapy in hemophilia A. And nowadays, what people ask very often is the pre-implantation genetic diagnosis. So I thought I'll take this forum to little bit tell the challenges in these. So as we know, first thing is cost. So as we know, as of now, both gene therapy and PGD are expensive. Gene therapy is very, very expensive, but we hope that eventually it will be reachable to all. In pre-implantation genetic diagnosis, there are some inherent technical issues, particularly with hemophilia A. So the technique is that the embryos created they are done by in vitro fertilization and then tested for hemophilia genes. So only unaffected embryos are then implanted. So these are some of the current challenges because of the complexity of the factor 8 gene and the technicalities involved. As I told you, it's a big gene. It has it has complex mutations. So it is very, very difficult to identify these variants from a single cell. So these are challenges that can be there. Plus, there could be ethical concerns because what we are doing is we are doing embryo selection. Now here when you're talking about X-linked recessive, then embryo selection could mean bring a lot of ethical concerns that need to be addressed. So what is the role of community medicine here overall? So one, everybody acknowledges awareness programs. We need awareness programs to educate public and caregivers about hemophilia and its inheritance. We need screening initiatives to implement carrier screening programs in affected families, because we see this practically. Even though a person or a family has hemophilics, the carrier testing of the lady is not done till she reaches advanced pregnancy. So that is something which is disturbing. Despite of having hemophilics in the family, somewhere there is a gap in communication or something needs to be done about that. Support services provide resources and support to affected individuals and family, and advocacy is supporting access to treatment and genetic services as well, because carrier testing, though we are in a tertiary center, we can offer on a very subsidized rate, but patients still have to travel, or even that cost many times is not possible to some of these patients. As far as possible, we do not charge patients who are below poverty line, obviously, but otherwise even the minimum charge is too much for some of the patients. So to summarize quickly, we know hemophilia is a genetic disorder with significant health implications, and the advances which are coming up both in therapy and prevention strategy will go a long way. And in the future, we know that the gene therapy is just around the corner, and there are other novel therapies which madam also briefed in the little bit about rebalancing and others. So these are promising in for the upcoming future, and we need expansion of the prevention programs and the genetic services in hemophilia. And we all know this document, the guidelines we do follow, and I encourage everyone to read this. So this is my small team from ICMR and IIH Mumbai. One thing I would like to put here is I'm lucky to be in a generation of caregivers where as madam said in the earlier, that they had to make the reagents. My earlier mentors, they had to make the reagent, do everything manually. So I was just fortunate to be placed in this area just in time where I did some manual things, and then the automated coagulometers came and the reagents came. So life has it gives a satisfaction that we are able to do things the way we want to do it, and we just hope that we keep doing good for the community. Thank you very much.
Dr. Kulkarni. I would like our CEO, Saranga Pawarji, to kindly come and felicitate Dr. Kulkarni. For our next session, I would like to invite Dr. Colonel Jyoti Kotpal. She will be enlightening us about laboratory workshops in bleeding disorders. Put your hands together.
I think I will be standing between you all and your dinner. So I'll just try to go as fast as possible on just important issues. So basically this is the topic which was given to me 2 days back. And well, I would just like to tell you that someone was talking about the EDL, and I was in the ICMR for the essential drug list as well as for the NHM committee. Emicizumab has not come into the EDL because there is no setup for taking care of the side effects. That is why, like Novo Nordisk has been doing inhibitors when Novo 7 came up, we need to have a central lab doing chromogenic assay where they will take for all the patients they are giving if there is an effect. Maybe one patient will have one problem in a year. At that time to be able to do the chromogenic assay, because to ask private labs to start it, it's not cost effective with patients, so no one is going to start it. So there are 2 centers, one IIH Mumbai doing, one CMC Vellore, maybe PGI Chandigarh is starting, no one else is doing the chromogenic assay. So that is very, very important, because patient will have a normal APTT, normal factor 8, and if there's an emergency surgery, how much factor 8 do you have to give? Are there inhibitors present? Your Bethesda will come normal, because the one which we are doing normally will not work on a patient on emicizumab. So with that, I move on to the basics. So this was the myth. People used to say PTA, PTT, and I'm telling you, I'm an NQAS assessor for the Government of India, National Quality Assurance Stand, and I've been to district hospitals, which are now going to become medical colleges even in your state, madam, they are still doing BTCT, pre-surgery. So if someone is doing BTCT, it's going to miss mild to moderate hemophilia and mild to moderate thrombocytopenia. Someone who has severe thrombocytopenia will have petechiae. Someone who has severe hemophilia will already have some ecchymosis or some history. So a BTCT is going to cause lots and lots of problem, and you may have moderate or mild hemophilias bleeding to death during surgery because they are doing BTCT pre-surgery. So I just go back, you know, I just finished my hematology super specialty in 99 from AIMS. I'm very old, I'm a 62. I've got a 36-year-old son who's an associate professor in endocrinology in the US. So I've spent 30 years in the army and 10 years I'm heading hematology at Sir Gangaram Hospital. This man, after service, they become DSC guards. So after they retire around 50 from the army, and he was a DSC guard and he had chronic bleeding hemorrhoids. And I had just reached Udhampur after doing my hematology, and he had bled, and the surgeon had done BTCT, done a hemorrhoidectomy, and he bled. We had to give him, those days there were no components in Command Hospital Udhampur, we had to give him fresh blood. And so I went to him and I questioned him, and he said yes, he had a past history of bleeding. When I asked, तो कहता है मेरा फौज जब ज्वाइन करना था DNS था 22 साल की उम्र में, DNS सर्जरी जब हुआ तो 20 बॉटल ब्लड चढ़ा था. तो मैंने कहा आपने डॉक्टर साहब को बताया क्यों नहीं? बोला डॉक्टर साहब, ही वॉज सीताराम घोष माई बैचमेट, GI सर्जन, ही हैड आल्सो डन फ्रॉम एम्स, पक्का बंगाली. डॉक्टर साहब बोला तुमको बवासीर है, हम काटेगा, तुम ठीक हो जाएगा. उन्होंने मुझसे पूछा नहीं, मैंने बताया नहीं. मैं 22 साल पुरानी बात क्यों बताता? तो what is most important is not BTCT, what is most important is history. So all doctors, all people working to find out likely hemophiliacs, likely bleeding disorders, history is very, very important. So I did a PT APTT. APTT is another test which most hospitals don't do. Go to a district hospital, they are doing CBC and PT. No one wants to PT, and PT means they also say INR. INR is only for monitoring oral anticoagulant, vitamin K anticoagulant. It is PT compared to the ratio and to the MNPT. That is important. Anyway, APTT was prolonged, so I just had fresh plasma. I mixed it up. When it got corrected, it had to be bleeding 8 or 9 deficiency. So 8 was 17% and 9 was 70. So he was just a mild hemophiliac who, if we hadn't given him so much products, would have bled to death. It's very, very interesting that 2 years back from now, he's an elderly retired soldier from the DSC also. After army, he's retired, and he got factors. Now, when we were getting the blood-derived factors, we did not have so many inhibitors. It's after the monoclonal that we're getting more and more people getting inhibitors, even mild. Today, he's got severe inhibitors, and my own hospital, army hospital, after I left, they stopped doing Bethesda SS, so he came to Gangaram Hospital to get Bethesda done. And he's got inhibitors. So now he's on bypassing agent. So you just see the thing that maybe if he had not bled, maybe he had been picked up by an APTT, maybe at that time when he had not been given factors, he may not have developed inhibitors. He would have been living nicely by told that you are just a mild hemophiliac, be careful, but you should know that you are a mild hemophiliac for certain situations. So this is a situation, so anyone comes with bleeding, a detailed history, a careful clinical examination. I'm not going into the big things for hematologists, it's for all of you, a screening laboratory test and specific. First step is detailed history. So pre-operative, 1983 it was said, and India we still don't follow. The guidelines clearly say bleeding history is most important. Minor surgery, just history. Negative, go ahead with surgery with a skin biopsy. Major surgery, a platelet count and APTT to rule out mild to moderate thrombocytopenia, low platelets, mild to moderate hemophilia. Because patient may not have a history. And if the history is equivocal, then you have to increase the number of tests, like we do for a bleeding disorder. Clot stability test for factor 13 deficiency, clot lysis test, bleeding time by IVs method, and so not the BTCT by the finger, that's useless. And if it's positive history for minor or major, you have to work up till you find out the cause and take care of that cause. So 1983 still updated, people are not following this pre-operatively, and so we have mild to moderate hemophiliacs, bleeding during surgery and then having problems. So we may even lose people. And here I want to just tell you that in such cases where the history is positive, because the normal APTT test may miss some cases of mild hemophilia, some 30% may be missed. APTT may be normal. So if there is a history, then you have to do factor 8 assay also depending on the clinical. So the workup has to go stepwise. So first thing is when anyone comes, so how are you going to pick up in the community? Very important in the family. I've had a doctor whose child developed hemophilia, you know, a Muslim in the army, consanguinity is there. Someone in the family had hemophilia, but it was not told. You know, the issue of not telling your family members that your child has mild hemophilia A. So, the sister, Masi doesn't tell the other sister, and the other sister has a child with severe hemophilia A. So, the cascade testing is missing in our country. So, I would like to tell with Hemophilia Federation at least, those are the severe ones who are coming forward. It is the mild and moderate. I have come across so many of them who during surgery come and said, yeah, I was diagnosed mild hemophilia B or hemophilia A years back. Now, or we pick them, but hasn't told anyone in the family. So that should be out. People should be able to get cascade testing done in the family. So that's very, very important. Going by what Dr. Kulkarni told you about the pattern of inheritance, you can see if the sister is an obligate carrier, then she should be tested so that you prevent the birth of a son with hemophilia A. All those things are very, very important. So we take the history to see whether it's acquired or inherited, because bleeding disorders can be both. We decide whether it's a vascular bleed or a platelet bleed, both have petechiae, or it's a coagulation bleed or it's a mixed bleed. So a mixed bleed will typically be because von Willebrand is the carrier of factor 8. If von Willebrand is very low, what will happen? Factor 8 half-life will become short. So severe type 1 will also have prolonged APTT. Type 3 will have very high APTT. And in type 2, type 2N, where the factor 8 catching area is spoiled, will have very high APTT, and they may be mistaken for hemophilia A because factor 8 will be low. So as Dr. Kulkarni clearly said, clear-cut diagnosis that it is not von Willebrand but hemophilia A becomes very, very important. And to tell you, in Delhi, AIMS does not do functional assay. They do only von Willebrand antigen and factor 8. In North India, Dr. Jasmina is here, PGI Chandigarh does all three. All three, factor 8, von Willebrand antigen and functional assay are the first screening test after you do a bleeding assessment tool score for von Willebrand disease. So we do it, I have set it up in my lab so that you can decide which direction to go forward. So the screening tests become very, very important depending on your first thing. So when you look at it, I'm not going into the details, but the type of bleed, but typically coagulation generalized, it will be since birth, if it is a fibrinogen deficiency, but if it is factor 8, it manifests after 6 to 8 months of age when the child starts crawling and then hits something and you get a ecchymosis or a hematoma. So it's very, very important. A child, 1-year-old coming with petechiae, what is it likely to be? Low platelets, ITP. A child born with a caput bleeding here, not an inherited disorder, it's most likely vitamin K deficiency. So PT, APTT both will be prolonged. So you have to take the complete history of a person with bleeding to decide how to investigate further. Also the examination to know whether it's a platelet type or a coagulation type or a mixed type. So when you are examining, if it's males, more likely to be hemophilia A and B if it's a severe bleeding. If it's females, more likely to be von Willebrand. It is autosomal dominant, so it comes from generation to generation. But the history will typical, माँ को bleeding ज़्यादा होता है periods में, उससे ज़्यादा history कई बारी नहीं मिलता von Willebrand disease में. this is what the petechia in platelet type of bleed, and this is what you get in hemophilia. Typically when the baby is around 6 to 8 months and hits something or gets injured. And this is what you'll get in Henoch-Schönlein purpura. So all bleeding disorders can be differentiated on the basis of examination. And this is the petechia you'll get in scrub typhus. Very bad disease, it kills people. Very, very important is sample collection. So everyone says get the test done. Sample collection should be atraumatic. Today we have vacutainers. I remember when we were young, as I said, we had to siliconize the glass tubes ourselves and put them in the hot air oven and then take samples for coagulation. Those were the days also we have all had work. Dr. Sita Lakshmi is here, she's also done the same thing. So 1:9 ratio is also very important. So someone has a high hemoglobin or a low hemoglobin, things will go higher. If you shift it at cold temperature, or it is a deficiency of factor 7 mild, or someone is on warfarin, and you put the tube in ice and send it to the lab, thinking it not get spoiled, there'll be cold activation of factor 7, you'll get false normal PT. APTT may become false high because cold chain is not maintained and factor 8 is a labile factor. I have had cases, a person with lupus anticoagulant in a lab, and what it turned out, it was a lab in Delhi near Batra Hospital. Dr. Chaudhary had sent the patient to me, and in Batra Hospital they had tied up with AIMS to do factor 8 or 9. So someone was collecting, the doctor there was collecting samples. Obviously the cold chain चुपके आप कहीं से underhand कराओगे तो कहाँ चलेगी? So factor 8 was given low. Factor 8 was absolutely normal because he was a normal person. He had APTT prolonged because of lupus anticoagulant. So it's very, very important to know the history and examine and how to collect the sample and how to transport the sample. This is someone has a very high hemoglobin, you have to reduce the citrate in the tube. Otherwise you'll get a false high PT and APTT because basically the citrates mix with the plasma. So someone has a very high hematocrit of PCV, plasma is less, so the anticoagulant becomes more. Especially newborn children, you'll have a false high PT, APTT. So you have to be very, very, or someone with a high hemoglobin will have a false high PT, APTT. So you have to correct it. So it happens very often. We get someone with a prolonged APTT and PT and they say common factor deficiency lightly, and when we realize it was wrongly collected sample. This is just to show you the coagulation screening pathway. APTT, olden days it was called Chiolin clotting time because Chiolin was the activator. Today silica, elagilic acid, all other activators are there. APTT tells you about intrinsic and common pathway. PT tells you about extrinsic factor 7 and common pathway. Thrombin time tells you about fibrinogen issue. It will be prolonged if there is fibrinogen deficiency or effect of heparin. And there is factor 13. PT is normal, APTT is normal, platelet count is normal. Would it be factor 13 deficiency? We have picked up 10 cases. In Delhi, we are the only center doing all factor assays. So we have 10 cases of factor 13 in the last 10 years since I started in Gangaram. When I joined Sir Gangaram, they were doing only factor 8 and 9. Today we are doing all factor assays and we have picked up cases referred from all over. So it's very, very important that one should know. So PT, APTT both prolonged, it could be factor 10 assay, common pathway assay. So we have to work up, and clot solubility is factor 13 assay, PT normal, APTT normal, platelet count normal, and there is a bleeding. And then you take the history, they said, oh, this baby, the mother says now that this 2 years child has come with intracerebral hemorrhage. Typically, mother says when the baby was born, there used to be oozing from the umbilical cord stump for 7 days. Typically factor 13 deficiency. So all this helps you in coming to a diagnosis. So when you do, bleeding time now is not in the screening methods. Bleeding time is out. If someone is bleeding, then you do IV's bleeding time with the template. So that finger prick bleeding time is out. And today thrombin time can be done. So the bleeding time can be this template bleeding time or IV's bleeding time, but the finger prick clotting time is also out. We use finger prick clotting time only for viper venom bite patients bedside when you are giving the anti-snake venom, no other place. Because it does not work in picking up cases. Platelet count, very, very important. You have something called EDT-induced pseudothrombocytopenia. Sometimes the sample is taken not mixed in time, so the platelets collect. Smear platelet count is very, very important. So smear platelet count tells you too low platelet is the cause of bleeding or not. And also it tells you other diseases. If you do a platelet count and you get such large platelets, you know it is a disease with large platelets. We'll come to that. It could be Bernard-Soulier. And if you see something like this with broken red cells, you know it is a microangiopathic hemolytic anemia which is causing low platelets. It could be a patient with TTP or heparin-induced thrombocytopenia. So, if someone is bleeding and you have done a IVs or a template bleeding time which is prolonged, look at the platelet count. Platelet count is normal, either it is vascular or it is platelet function defect. Platelet function defect is worked up by platelet aggregation studies. So, the commonest is non-steroidal anti-inflammatory drugs. Someone who's taken aspirin, brufen, Bovaran, ibuprofen. And the saddest part is in dengue, when the platelet come down, someone says fever nahi utar raha, isko ibuprofen de do, and then they bleed. Because it should be only plain paracetamol. And then there are the inherited disorders. I will not go into the details, and if the platelet count is low, all causes of low platelets from acute myeloid leukemia to lymphoblastic leukemia to ITP one has to work up for. So, for platelet function do we aggregation studies. We are doing aggregation studies, I think other than PGI Chandigarh and AIMS in North India. We are the only center in the private, so we get patients from Delhi, we get from Bihar, we get patients from Assam also coming for platelet function tests. Sometimes in bleeding disorders it's required. It is also required in von Willebrand disease. Now, it's very important in von Willebrand disease to diagnose type 2B von Willebrand disease, because these patients, if you give desmopressin, they'll have a clot and platelets will crash. So it's very, very important that in the second step, first step is 3 tests for von Willebrand disease, von Willebrand antigen, APTT and factor 8. Depending on that, we go to the second steps. So, I talked about von Willebrand. So, what is most important is the bleeding severity score. So, I'm not going into the details, but you have to do a score. More than 4 for adult males, more than 6 for females, and more than 3 for children is significant. So, after that, you work up for von Willebrand. So, as I said, you do a CBC, PT, APTT, fibrinogen, and you do the 3 tests and then you subclassify. I'm not going to the details, it's a class in itself, but 2N is the one which looks almost like hemophilia A. We do the ratio of the function to the antigen to subclassify. So if the function is low and antigen is not so low, it becomes type 2. If antigen is also low and function is concomitantly low, so we said concordant low function, ratio more than 0.7, it is type 1. And if it is going very low levels, then it is type 3. So that is the von Willebrand, because they were talking, the company people, that von Willebrand factor kab dena hai or factor 8 kab dena hai is very, very important. So basically coming back to when you have a prolonged APTT with a normal PT, it could be factor 8, 9, 11, 12 and contact factor deficiency. So someone has a bleeding, 8, 9. If 8, 9 comes normal, do 11. 11 are mild bleeders. All these 3 are normal, you do 12 and 12 is abnormal. You tell the patient you will not bleed during surgery. 12 deficiency does not cause bleeding. It prolongs your APTT to 100 seconds but does not cause bleeding. And contact factor deficiency, where we increase the contact in the APTT, this also does not cause bleeding. So you start with 8, commonest, do 9. If APTT alone is prolonged, if that is not abnormal, do 9. If that is also not abnormal, do 11. And take a decision on which hemophilia A, B, C or factor 12 deficiency it is. Similarly, if you have only prolonged PT, it is factor 7. And we have cases, we have picked up, and North India we have less cases of bleeding disorders compared to the South, because Hindus don't have the consanguinity, it's only in the Muslim population, but we have picked up cases of factor 7 deficiency. So it's not uncommon. And we picked up cases of factor 10, very interesting. This one young boy, 8-year-old, while playing games was having only bone pains. So the father took him to the orthopedic surgeon. maybe there were those micro bleeds on the surface of the cortex which was causing bone pains. And his PT and APTT both were prolonged. So he came to us and then we diagnosed him as factor 10 deficiency. They don't have the money, so they just give FFP whenever he has these aches or pains or bleeds. So diagnosis become very important, and when both are prolonged, then it is common pathway. In the olden days, we used to do mixing with adsorbed plasma and normal serum. Now, adsorbed plasma is very, very difficult to make. We were the old timers, we used to give 10 swirls and say, okay, you put aluminum when we were doing manual. Today that era is gone. So mix with normal plasma, look for correction, and used age serum. So if it is corrected with normal plasma and not corrected with age serum, it is factor 9. If it is corrected with normal plasma and also corrected with age serum, then it is 9, and not corrected with age serum, it is factor 8. So it's very simple, you can work it, but in the olden days we used to do these. So I just wanted to tell you that these were the methods we followed. Today we go straight for the factor essays just after mixing. But to tell you why mixing is important, 3 years back I attended a pediatric hemon conference, and the pediatric clinical hematologists were discussing, and they said 1:1 mix, 50% correction is factor deficiency. And I got up and said, no, 1:1 mix, more than 70% correction on APTT is factor deficiency, less than 58% correction is lupus anticoagulant or inhibitors, and in between can be both. So APTT 1:1 mix, correction into the normal reference range, or more than 70% correction means factor deficiency. So typically you have a preoperative patient with a 49.1 APTT prolonged. Now, is there a history of bleeding of medicines or no history? So it could be heparin contamination, it could be some drugs like dabigatran, direct thrombin inhibitor. They can cause the DOACs, or it could be lupus anticoagulant, or it could be factor deficiency. So we move in for a mixing. So in mixing, you mix patients, so any laboratory which is doing APTT under your National Health Mission, PT, APTT can do mixing studies, no one is ready to do it. 1:1 mix and do the APTT again and just calculate the correction percentage. You can say it is factor deficiency or it is inhibitors. Now, inhibitor screen, again people are not doing it. You have hemophiliacs being treated, you say inhibitors are only done in Ahmedabad. Why cannot every medical college in Gujarat or in Rajasthan or in Haryana do it? You have to just mix it. You have seen it's corrected. Then you keep this mix for 2 hours at 37 degrees to look for time and temperature dependent inhibitors. Factor 8 is deficient. Does this patient have inhibitors or not? That's what you want to look for. Baby who's diagnosed with hemophilia will get inhibitors later. So that's not a problem, but we have something called acquired hemophilia A also. So you have to mix and keep it for 2 hours. Now what has happened, I have had cases who have been diagnosed as inhibitors, children with hemophilia, some hospital, somewhere lab, private lab center sent and diagnosed as hemophilia with inhibitors because it was more than 5 seconds compared to the immediate mix. But what did they do? They did an immediate mix and then they kept it for 2 hours and they did it. But they forgot that the normal factor 5 and normal factor 8 in 2 hours at 37 will also go down. And that may have increased the factor. So it's very, very important that you keep the mix, you keep the control and plasma also together at 37 for 2 hours and mix it at the end of 2 hours. So I'll just show you a report to tell you how important it is. But this is just to show you the correction mixing, which I told you more than 70%. And just telling you a case of acquired hemophilia. So he had a periampullary cancer, but he had ecchymosis. So they said PT is prolonged slightly. It's a DIC. D-dimer was high because it was a cancer. So mixing studies, we did 96 seconds, it corrected to 35, and then we kept it at 2 hours. Now at 2 hours, it became 47. But the control mix became 41. So we have to take the seconds from what is kept for 2 hours and then mixed at the end. from the mix which is kept for 2 hours to call it inhibitor. So it's very, very important. False inhibitors should not also be given. And he turned out to have low factor 8 and then we treated him. So that's just to tell you. So there are acquired coagulation disorders which can also cause bleeding. So a prolonged APTT could be because of heparin, it could be because of factor inhibitors, it could be because of anticoagulants the patient is getting. Similarly for PT because of liver disease or vitamin K antagonists, and DIC will have both prolonged. So I will not go into the details how we do it, but you should know about it. And someone with a prolonged PT, APTT or thinking of factor 7 deficiency, please give injection vitamin K and repeat it. Because sometimes it could be liver disease or it could be deficiency of vitamin K. Someone is taking antibiotics, not taking enough green leafy vegetables, may have prolonged PT, APTT, causing 2, 7, 9, 10 are vitamin K dependent factors, and you will have both prolonged. Very, very important. With this, I just move on to something called DIC. Why I'm talking about DIC in a bleeding? Because it's an important issue. We have a scoring system, and this also looks at PT, platelet count, fibrinogen, and D-dimer. So this is a DIC score. A clinician decides someone has disseminated intravascular coagulation. Now, issue comes up of PPH. Why? Because I am just telling you here for the doctors in PPH, and that's why in the district hospitals I've made fibrinogen part of the PT, APTT fibrinogen. Fibrinogen is very, very important. Whatever the cause of PPH, all patients have a crash in fibrinogen, and that kills. The only thing which needs to be corrected is fibrinogen. And what doctors do not know, I have met gynecologists all over the country, that fibrinogen, what is normally 2 to 4 grams, becomes 4 to 8 grams in third trimester. And anyone with less than 2 grams will bleed to death. We have to correct it above 3 grams. So that level of fibrinogen one has to know. And DIC score does not work because fibrinogen is high, D-dimer is high, factors are all high in pregnancy. So you have to just look at fibrinogen. More than 4, no risk of bleeding. Less than 2, 100% risk of bleeding. So any lady who's bleeding, do fibrinogen and correct it with cryo or fibrinogen and not with FFP. It will make it crash. And I'm not going into the details, but we have established the ROTAM-based testing for PPH, which is a point of care test. And with this, I'm not going into the details, followed a patient, there's very shortage of time. But by this point of care device, you can pick up thrombocytopenia within 15 minutes. You can pick up fibrinogen deficiency. You can pick up hyperfibrinolysis, which is PT, APTT, TT, everything normal and patient is bleeding, hyperfibrinolysis. You can pick up that. You can pick up the effect of heparin. You can pick up the effects of diarrheal oral anticoagulants. For this patient of PPH, we do, and now we use this algorithm. I'm not going into the details, but all products are decided on the basis of 5 minutes ROTAM report in PPH. And it correlates with fibrinogen level. So ROTAM, FIBTEM, and XTEM at 5 minutes, and you can treat. We've done this, we presented it at the ISCTH conference, and basically we found that fibrinogen level is most important, and we found that any fibrinogen less than 2.79 PPH was moderate to severe. So we have to correct it above 3 in all these patients. And then just to tell you, this was a 24-year-old lady. She had a liver disease. Now liver disease, they say, will bleed. She had a high INR, but we know liver disease with a high INR can have clotting. So platelet counts were fine, and we did this and we find hyperfibrinolysis. So this kind of hyperfibrinolysis in ROTAM, we cannot pick it up with a routine test. PT, APTT normal. Here PT was high because it was a liver disease. It could be hyperfibrinolysis requiring tranexamic acid, or it could be a concomitant factor 13 deficiency, which we have to work up for. So this is important, and I just want to tell you that we have used this point of care test. So when we are talking about chromogenic assay, which is expensive, you have to buy very expensive kits. So we validated, we published it in Blood Research last year. We validated the demograms on ROTEM to pick up inhibitors in hemophilia. So this is the paper, assessment of phenotype of hemophilia A. And if you look at this, just on intent, we can say this is mild, this is a moderate with severe phenotype, this is a severe phenotype, and this is a severe with inhibitors. And we developed ROC curves, cutoffs. So this is a point of care device. Now with imisuzzumab in the era, we have done it for inhibitors. Now with imisuzzumab patients, we can again validate and see whether this point advantage is, though it's an expensive test, chromogenic turns out to be more expensive because you buy a kit of 96 tests and it expires, you do for 2 patients. Here you can do one test at a time. It costs around 8,000, but it will tell you just by using the intrinsic pathway method that whether APTT is normal, factor VIII is normal, Bethesda is normal, because patient is on imisuzzumab and emergency surgery is required. At this juncture, this test needs to be validated. We haven't validated because we don't have patients on imisuzzumab, but we validated on normal inhibitors patients. So this is something which can do, and if we can do it on 20 patients on imisuzzumab and know their factor levels or severity of hemophilia which they have, at least when they have to be shifted to an emergency surgery, use it. We haven't done it, but this is some research one can do in future.
Thank you very much, Dr. Jyoti. To wrap up today's session, we'll head now to the last presentation of the day. I'd like to invite Dr. Latika Nipram from NIGRMIMS. Dr. Latika, please.
Very good evening to everyone. At the outset, I would like to thank Prem and HFI team for giving me this opportunity to speak on the overview of laboratory diagnosis of hemophilia. Before I begin, I would like to mention here and appreciate what Sir Kulkarni and Madam Jyoti has given such an excellent, very interesting aspects on the laboratory diagnosis of bleeding disorders as well as hemophilia, and my work is made easy. So, being the last speaker, I will not speak so much, but I'll just touch on this the very important points only, and I will not elaborate because we have very less time now and dinner is awaiting us. So, okay, I will not go into these details as well. The theme of World Hemophilia Day 2025 is Access for All Women and Girls Bleed Too. And as we have seen through the various presentations, how women also can be affected by bleeding disorders and that we have to take care of them, the theme being of this year. So as the words of the President of the World Federation of Hemophilia has mentioned, that today women and girls with bleeding disorders are still underdiagnosed and underserved. The global bleeding disorders community has the power and the responsibility to change this. Through recognition, diagnosis, treatment and care, the quality of life of women and girls will improve and the bleeding disorders community will become stronger. I think we have to take a resolve to take care of women with bleeding disorders. I will not go into details, as we all know about it. Now, how can a patient be identified? First of all, as Ma'am Jyoti also said, history is the most important aspect. From there on, you can proceed to whichever direction is appropriate. So The known carriers, carrier mothers shortly after birth of an affected child, you can see. Unknown carriers, spontaneous bleeding, and the various types of bleeding symptoms as we all know. Now, how to establish a diagnosis? There are battery of tests, as already mentioned also, and which I will not go into details because we all know it one by one. We'll just see, let's just touching the tips. As this is a mixed crowd, I will not go into much detail. Now, regarding sample collection, it is extremely important how the sample collection is performed, and that also has been already explained. Should be obtained quickly without venipuncture, a good venipuncture at first instance, and the blood should be drawn gently and not very vigorously. Gentle inversions up to 5 times should be done for mixing the anticoagulant with the blood without delay. And trisodium citrate dehydrate at the ratio of 9:1 proportion, and we always use platelet poor plasma that is made after centrifuging at 1700 for G for 10 minutes. And the test should be ideally performed within 4 hours, and if we cannot, we can store it at -70 and below for 6 months. Now, we know the different diagnostic tests that will lead to the diagnosis, proper diagnosis of hemophilia. So we have the APTT, as has been emphasized again and again. APTT is so extremely important. It is a non-specific test of the intrinsic system. In conjunction with PT, it is the most useful screening test for detecting deficiencies of factor 8, 9, 11, and 12. And the normal range should be established locally. It doesn't depend on set international level, but it has to be all established locally. And a correction of more than 50% of the difference between the normal and test plasma, results of the normal and test plasma, if it is more than 50%, then it is considered a correction. So as we know that if it is corrected by a 50-50 mix, it is considered a good correction, more than 50% of the difference. If it is not, then we know that it could be an inhibitor presence. Now, once we have got an isolated prolonged APTT, how do we proceed? We do a TT. If it is prolonged, we repeat in the presence of protamine sulfate. If it is corrected, you undergo the next step, that is mixing studies. And then furthermore, then we usually use, if the APTT is prolonged, we have to see another reagent with high phospholipid level like actin-FS. So if both APTTs are prolonged, then we have to perform factor assays. If the APTT level in the first was high and with actin-FS is low or normal, then we don't need to proceed ahead. But if both runs are prolonged, then we proceed for factor assays. Now, we've also heard about mixing studies. It's performed on further investigation following an abnormal APTT. Now, the agents used are normal plasma, aged plasma, as we have heard also, deficient in factor 5 and factor 8, adsorbed plasma, deficient in factor 2, 7, 9, and 10, and nowadays, instead of using aged plasma or adsorbed plasma, we use factor 8 deficient or factor 9 deficient plasma. Now, this has been mentioned. This is the overall picture of how to interpret whether there is factor deficiency or it is a normal correction has been done, or abnormal or not yet corrected. Then we identify whether there is presence of inhibitor or just a clotting factor deficiency. So now we go to the factor assays. After we have identified by mixing studies whether there is a clotting factor deficiency, then we go for factor assay, of which we have two types of techniques. One is APTT based one-stage clotting assay and the chromogenic substrate assay. Now, majority of the cases, 93% worldwide is mostly is the one-stage clotting assay, and around 3.7% is chromogenic assay estimation being done. Now, on one-stage clotting assay, the principle is based on the ability of the dilutions of standard and test plasmas to correct APTT of a plasma known to be totally deficient in factor 8. Containing all the other required factors. This is the principle, and it is at one go only all the reagents are mixed, and then the test proceeds with the final addition of the calcium chloride. Now, there are limitations of the one-stage assay. Interference by lupus anticoagulant, this is a major factor. That is why we go ahead with performing the chromogenic assay, and or if we can, then we go for some other reagent like where high phospholipid content is there. Mild hemophilia cannot be excluded, which may give a normal result. So mild hemophilia may, by this one-stage assay, you may get a normal result, and then you may miss the diagnosis of mild hemophilia, which ma'am also has given a very clear example. Usually 2 times, the result is 2 times higher of the chromogenic substrate assay. The results usually are given by the one-stage assay. Now let's see about the chromogenic substrate assay. The principle is factor 8 is activated by thrombin. It is a 2-stage assay. The activated factor 8 accelerates the conversion of factor 10 to 10A in the presence of factor 9, activated factor 9, phospholipids and calcium ions. Then in the next stage, the factor 10A activity is assessed by the hydrolysis of the chromogenic substrate, which gives a different color, which is measured at a 405 nanometer wavelength, which is proportional to the factor 10A activity, and which correlates with the factor 8 activity, and that is how we have a 2-stage chromogenic assay. This is just to identify that this is 1-stage assay, and this is a 2-stage chromogenic substrate assay. Now, after we have identified and treatment has started, many times we get inhibitor assays, the possibility of inhibitors coming into the scenario. We all know about inhibitors, what is inhibitor and what is Bethesda unit, and time dependent and factor types, inhibitor types. So this is also the inhibitor screening. Ma'am was also mentioned already that you take 4 tubes basically, and then you have normal plasma, test plasma, and equal mixture, and then incubate them, and then stop the mixture after 2 hours by placing them on ice. And then also there is an immediate mix happening between normal plasma and tube 1 and tube 2, that is normal plasma and test plasma, after incubation separately and mixed immediately. So that is tube number 4, and we perform the APTT on all tubes. This is the inhibitor screening interpretation. Based on this, you'll be able to identify whether the result is absolutely normal, clotting factor deficiency, immediate acting inhibitor, or time-dependent inhibitor. Now, this is the inhibitor detection Nijmegen Bethesda assay, where serial double dilutions of the test plasma is performed and then mixed with buffered pool plasma, and then we make the inhibitors work and then assess the residual factor later after the incubation. Now, we have also seen about von Willebrand's factor causing issues with in the diagnosis of mild hemophilia, so I will not go into details, as we all know. And next comes the assay discrepancies. Let's just look a little bit about the assay discrepancies. Between one-stage assay and chromogenic substrate assay, there have been observed different kinds of assay discrepancies. These are associated with certain genetic mutations, and the WFH guideline recommends that the use of more than one type of factor assay is required for the detection and classification of all forms of hemophilia A and B. So, and we have to encourage every center to start having both assays to have a correct diagnosis of hemophilia, all forms of hemophilia. Now we will come to a little bit about the monitoring of factors and drugs. We see that for plasma-derived and recombinant factor concentrates, the one-stage assay gives a lower factor 8 activity. More so it is seen more frequently seen with extended half-life factor concentrates. Now, about emicizumab also we have already heard about. Emicizumab usually does not require activation and is not subject to the regulation. It leads to significant shortening of the APTT-based clotting times, even at subtherapeutic plasma concentrations. And it requires no thrombin-mediated feedback activation, but is active as it is. That is why we have problems in trying to understand the factor activity level. So APTT-based one-stage clotting assays for detection of plasma factor activity exhibit clotting times outside the dynamic range of the test system. That is why it should be detected by chromogenic substrate assays. And the one solution can be use of bovine factors for chromogenic assay rather than human derived. It can measure the endogenous or exogenous factor 8 in the presence of emicizumab, as it only binds, emicizumab only binds to human factor 9 or factor 10. In conclusion, hemophilia is a hereditary X-linked disorder, as we all know. Can be suspected based on the bleeding patterns from childhood. A battery of tests are available for the diagnosis and coming to a conclusion of hemophilia. Both one-stage and chromogenic substrate assays are required for the diagnosis and classification of severity. Emicizumab causes shortening of the APTT-based clotting times, and use of bovine factors for chromogenic substrate assays help measure factor 8 in the presence of emicizumab. With this, I end my talk. Thank you very much.
Thank you, Dr. Lutika. I would like to request our RCC East, Shri Chittaranjan Das, to come to the stage and felicitate Dr. Lutika. With this, we wrap up our sessions for today. I request everyone to kindly proceed and have their dinner. Thank you all for being such a patient audience, and we will continue our sessions tomorrow.